Hello, a very good day to all my friends out there. This is your mentor, Sidrali this side. Is my voice audible and clear to all of you? Can you all hear me?
Yes,
Hello,
yes,
how are
Dr.
you doing, Dr. Sajata? Hello, Girija. Hi, Dua. Hello, Ramya. Hi, Dipti. I hope you all are fine. Thank you very much for joining in. Where are others? Dr. Dipti, please drop in a message in the main group. Everybody has to join in. A long journey with you guys, with breaks, with pauses. Sexual and reproductive health was the first module, and today we are going to do gynecological oncology. We'll try to make it easy. Moreover, after this module, I'm going to put in the schedule for the first group for you guys, and you're going to start with the first group in your mini groups practice, please, so that now in the next 2 months, all the books they start getting revised. You're going to do those stations. Sidewise, you will be revising one module from the exam stations from the back. All right. Okay, so Girija has not joined yet. Hello, Galaxy S10. Who are you? Hi, Galaxy S10. Who is this student of mine? Dua? No, Dua names appear as Dua's iPad. Hello, Dr. Sabia. 12345. How are you doing? Thank you very much, Abir. How are you doing, Abir? How's health? All right, thank you. So, all the presenters to be fast readers, every word is important. This time, Abir, Group A was doing practice, and Dr. Sabiha was somehow taking the lead. Yeah, so I was happy to see you guys. Now, in oncology, friends, we have cut the pre malignant lesions and we have cut the malignancies. The pre-malignant lesions in terms of the cervical screening, HPV testing, that's a very common station that came in one of the tests, and now the extended match questions from the January exam, that was also with the new HPV triage. Endometrial hyperplasia, VIN, lichen sclerosis, the premalignant conditions of all cervix, endometrium, vulva, they all are important. The malignancies, like that of the cancer, endometrium, cervix, ovary, vulva, they all are important. The BRCA gene positive, how to deal with that situation with the risk reducing salpingo oophorectomy. The related information leaflets we have. Now, I would request all of you that whenever the oncology module is being discussed or you people are revising the oncology module, always take care of your empathy. Always take care of the breaking bad news. Empathy indeed is being tested in this station. Don't be blunt. Avoid being fast. Take pauses. Take care of the patient's response. If she's weeping, please give her a little pause and provide with the tissue papers and the water if it's available. Ask the history according to the complaints, like that of a urine, lump, meds, abdominal pain, the menstrual cycle, the pressure, symptoms. Then complete your gynecological obstetric, the medical family history, the surgical history, drugs, allergy, all need to be completed. You complete the personal history, the social, the mental health, examine the patient. Never forget MDT in oncology. You are not going to deal with this patient alone. It's going to be the team of doctors taking care of that situation. And the treatment would be according to the cause in the station. And you provide the information leaflet and you do a good closure to your oncology module. All right. So let me see the participants now. Dr. Sabia, how are you doing? Hello, Servat. I hope you're fine. Where's Dr. Atia? Abhi, drop in a message in the A group for Dr. Atia that I'm waiting for her. All right, thank you. So where is Group B and where is Divya and Group? Okay, so who's the first presenter today? We've got Ramya here. Then it's going to be, instead of Dr. Bindu, Dr. Sujata, you're doing the station, right?
Yes.
Okay, that's great. So second would be Dr. Sujata. Then we are going to take Jyoti. Jyoti, join in, please. We are waiting for you. Then it's going to be Pallavi. Then Dipti. And oopsie, I think we shifted Pallavi to the list now. All right, I'll sort it out. All right, then it's going to be Girija, and actually Dr. Fawzia had her shifting, so she wanted to do her station alone with me later. So we'll see if we have to shift the station somewhere else, or once she'll do with me, I can share the recording with you guys. All right. Okay. So can we have Ramya here? Hello, Ramya.
Hello, good evening, Sandra.
Hello, good evening from my side. How are you doing?
Yeah, good.
How's everything going?
Very slow.
I can understand. What about the hospital? Hospital has slowed down as well?
Yeah,
Oh, really? Hospital
yeah,
has slowed
really.
down?
But hospital slowed down with respect to COVID cases at the
Ah,
moment.
that's fine. So COVID is getting better, yeah?
Yeah,
Oh,
expecting a hike, but at the moment it's on a lower side.
that's really good. That's something we were waiting for in India because it's been a long when the second wave people announced. I was getting from the students is that the first wave is not over and they're saying the second wave. So there was no pause in between, yeah?
Mm,
So that's good to know, my dear. All right, so we can listen to your voice clearly, and your voice is audible. So let's
okay,
start the first station, and the 2 minutes are going to be started now. Then we are going to
okay,
take the 10 minutes. So please start your time. Thank you.
okay. Next page, please.
Can we start?
Yes.
Start, please.
Hi, I'm Dr. Ramya, one of the doctors in the gynec clinic today. May I confirm your name and age, please?
Hello, doctor. Doctor, I'm Mrs. Mary Wilson. I'm 62 years.
Okay. How may I address you?
Yeah, Mary is all right.
Okay. Mary, I have gathered from your case notes that you are here because you're having a long-standing itching in your private part. Am I correct?
Yeah, exactly. It's worsening day by day, doctor.
Yeah, I understand that. Surely in the next few minutes, I'll be discussing about all your problems, address your concerns, and mutually we'll come to a safe and management plan. How does that sound to you, Mary?
Yeah, thank you very much, doctor. That is a relief.
Yeah. Can I ask you a few questions so that I can understand more about you?
Yeah.
Okay. Um, may I know more about your problem?
Okay, so the problem started around 6 months back. I started feeling a little itch down below, and I found that my vulva that is a little sensitive. I thought it's some sort of an irritation I'm having, but with passage of time, it worsened. I went to GP, and he gave me a steroid. If I'm not wrong, hydrocortisone, and I started
Okay.
taking that steroid. And believe me, I've used it 2 months, and things are worsened to the level that now this itch is not only in vulva, that's going to the back passage. I mean, it's worsening, doctor. It's not improving at all. And now it's soreness to the extent that it's very uncomfortable, doctor. Please help me out.
I'm so sorry, Mary. This really affects your quality of life, and I
Yeah.
can understand your concern. Okay. And so, do you have any other associated symptoms, any
Like
other problems other than this itching?
any
Any
other problem
bleeding,
hasn't? No.
bleeding
Prob-
down from your private part?
no, no, nothing, nothing.
Any abnormal discharge you appreciate down?
Not exactly, no, doctor.
Okay. Or any problems with your waterworks
No,
and opening of bowels?
no.
Okay. And can you may I know like when you reached your menopause, the last periods?
Yeah, that was around 52 years of age. That's 10 years ago.
Okay. May I check how many children you have and about
Yeah,
your children?
Yes, I've got three kids. They're grown up.
Okay, were all normal deliveries?
They were, yes.
Okay. And Mary, are you update with your smears?
My screening had been fine. No problem with that.
So we're all normal. Okay.
Yeah, yeah.
And are you otherwise fit and well? Uh,
I don't have any other problem. Anything in specific you would like to know?
yeah, maybe about your sugar levels, diabetic status?
No, things are fine.
Okay. Have you been underwent any surgeries in your operation in your tummy or down below?
No, doctor.
Okay. Any family history of concern you like to share with me?
Anything specific? No, I don't know anything of importance.
Any sinisters in your family members?
No,
Okay. And are you allergic to any medicines?
I'm not.
Okay. May I know you smoke, drink?
Yeah, I do smoke. I do not
Okay.
drink. Yeah.
Okay. May I check how many cigarettes you smoke per day?
Around 3 to 4, not more than
Okay.
that. Yeah.
Okay. Have you ever thought about quitting that? Maybe.
Not exactly.
Okay. Doing smoking is it's not giving a good effects for overall health as well. And for the complaints, whatever you experience with all the troubles you have, this may aggravate the problem. So, in any chance, in case if you think of quitting this, that would really improve your symptoms,
I see.
kind of
I'll think
contribute
about.
in improving.
I'll think about that, doctor.
Yeah, I appreciate that, Mary. And pardon to ask, any recreational drugs?
No, doctor.
Okay. Uh, so, what do you do for your living, Mary?
Yeah, I work as a teacher.
Okay, okay. So here I have your GP findings. So, and you have been as per your word that you have been using that what so-called hydrocortisone steroids to get the relief done. And so, have your GP ever discussed with your problem?
I discussed in detail with GP, and he gave me this tube to treat this condition.
Okay. Okay. So it's been there for you with 6 months, and it's the whatever the drugs it's not given to you, it's not working.
Yeah,
Have you understood like what's really happening with you?
I don't know. He did examine me. He said that I need to meet you.
Yeah, I had just confirmed your name, age, and NHS number, and these are the findings whatever being shared with me. Um, so what I could appreciate is there is a reddened areas in your vulval area. Vulvas we call the lips of the vagina in the private part. So there is a red areas and there can be small crack like appearances in your vulva. So at any point you heard about a term called a condition called lichen sclerosis?
What is that, doctor?
Okay, so it's a kind of skin condition that affects the vulval part. That's the lips of the vagina. So it's one of the skin conditions that happens because when there is a long standing we call as when the body's own immune system sometimes it works against our own body cells. Sometimes if that happens there can be abnormal changes in your private part like this, and this will give you a long term itching and the kind of soreness whatever you describe. Am I making
See.
clear?
Yeah, I get that. I mean, is it something serious or is it like something which is treatable? Because I'm not getting better with any of the medication.
Yeah, I can understand your concern, maybe. Yeah, so we can. This condition is treatable, but we always encourage you to be under follow up with us, so that we can understand how much it's getting clear. Um, and whatever the ointment you use is a very milder form. So what we do, the so-called steroids, there is a very potent steroids called as strong steroids. If we so apply available in an ointment form, you can apply in your local wherever the problem we have with the vulval area, wherever the abnormal areas we you have. So in case if you apply this as per the prescription on a a lowering dose, reducing the dose, initially we'll give a higher dose for you, so you have to apply daily over the
What
area.
what medication?
So some drug we call as clobetasol. This is very strong steroids that really helps for your condition,
Again,
Mary.
steroid, doctor. Steroids are not working on me.
Okay, I understand. Whatever the steroid you have been using so far is not that much potent. It's a less potent steroid. This because these condition they work, they respond better when you use a very ultra potent. We call it a strong steroids. So
Is
you
it
the
like I have to
clobetasol.
eat that?
Excuse me.
I have to eat that? I mean,
No, no,
these
that's you can apply. It's a kind of ointment you have to apply over the abdominal area.
I see. Okay.
Okay. Okay, so we'll give you a special instruction. Take a fingertip of the cream, apply gently over the abnormal areas down in your vulva. So initially we'll I encourage you to use daily for first month, and then alternative days for the next month, and then we'll slowly taper down, and I advise you to take twice daily, twice weekly in the third month. So with this kind of usage, slowly you will feel like improving of the symptoms,
Mm-hmm.
and uh, though with the improvements, still we encourage you to have a follow up with this. Why?
Oh,
Because
what if
and
it doesn't work? I mean,
so in case if it is not working, then uh, we may need to take a small tissue of the abnormal area and send it for a biopsy examination to look whether any abnormal cells we could really find it over there, because there is a very small chances there can be a sinister cells uh, uh, behind this abnormal areas. It can be very small risk only. That's why we always advise you to come for a follow up with this.
I see. All right. So what do I need to do now? I just need to start applying this
Start
medicine.
applying this medicine, as well as a general advices to not to use any irritants, like taking a shower baths or using soap or any other uh, fragrances close to your vulval area. And always we'll advise you to go for a loose fitting undergarments. And even if you have a look, or you if yourself have a look into the private part using a mirror, if any new changes you observe, we would always ask you to come to us immediately.
I get that, doctor. All right.
So is there anything I should
That's okay. I
address?
understand that. All right. Yeah.
Okay, thank you, Mary.
Leaflet.
This is a patient information leaflet. You
Hmm.
can go through it, and in any case you have any queries, please come back to us, and we are here to help you, Mary.
Thank you very much. Thank you. All right. So, how did the station go, Ramya? Long time no
Very
see.
fumbling,
Yeah?
fumbling here.
Listening to your voice after a long time. Yes, Girija,
Me
Jyoti,
also felt the
Akir.
same.
Girija is happy with the presentation. Yeah. So, Girija is always there to encourage you. Thank you
Yeah,
very
she
much,
always
Girija.
motivates.
All right. So, how did the station go? Otherwise, anywhere you were feeling difficulty in any part, or you were, yeah, the fumbling was there today. That is
Mm-hmm.
because of the lack of practice. That's not
Yeah,
actually
definitely.
the actual Ramya. When you start practicing, your flow gets better. I know you. So
Mm,
that is only that part of lack of practice for which the fumbling was there today. But
yes.
tell me that anywhere you were having a little difficulty in any sort of a domain, may that be information gathering or was there in applied clinical knowledge, were you confident?
Information gathering, I think I'm confident.
Okay.
In communicating with the patient, maybe the terms whatever I used to describe Mary would have been more easy and fluent.
Okay.
And yeah, basically there is no practice.
I can understand. How would we start practicing Ramya?
Daily we have to present.
Yeah. Jyoti, how would we all start practicing? Girija? Dr. Sabiha, how are we all going to start practice? 6th March is exam for my two of the students. January result is still not out. So
When
the
we
thing
will
is,
book the exam?
That's being so honest, Dr. Sabia. That's being
Yeah.
honest. I know what.
Alhamdulillah, I'm always honest with everybody.
And no, that is actually something which you'll be honest with yourself and you'll be knowing this is my exam date. You know, so up till now, the thing is that because you people are not sure, are we appearing, are we not appearing, will we get registered or not? So that's the reason actually that, you people are having this difficulty. I understand.
Yeah.
what you say, the urgency is not coming. Like
I know,
we have sort of really lagged down. Like we
I
haven't
know,
been
I know.
saying.
So
Always we talk about this like we have to study, like we try to motivate, but still, as we are not
then what happens
aware
is
of the exam dates.
exactly. Then what happens is that other priorities, other things you think that it is a priority now. At the moment, exam is not a surety, so it
Yeah.
becomes least down in the priority. Am I right?
Yes. Yes.
Yeah,
Yeah,
I mean,
It's
the
not coming in
priority
the
is
list
always there.
exactly.
It's the most important thing. But the thing is, like, since we don't know, there are other things which needs to be done, and we start doing those things,
true,
which is
true.
not right.
I can understand.
We
No
will get
problem. At
actually
least all the exam
more
stations are done with you guys. The only thing is that now it's going to be, yes, exactly. The uncertainty basically makes us go easy. But let's see in the coming weeks, hopefully things would be fine, especially after 6 once the exam is done. So it's 2 p.m. The exam would be starting on the 6th. So hopefully after this, the college is going to open up the registration. So things would be better. All right. So there were many good points. Let's appreciate first. Introduction was smooth. It was good. Agenda making as well. Information gathering. Ramya followed the rule, and it was an open question. And she was saying yes, sorry for whatever has been happening with Mrs. Mary Wilson, and she did ask about the bleeding, any problem with the waterworks, when was the menopause, in the gynecological history, in the obstetric history about her kids, how were they born, and she did ask in the medical history specifically about the diabetes, in the surgical history, the allergy, the smoking. She did appreciate that I would try to cut it down if at all I'm understanding this point that this would worsen the situation. So she did confirm the examination and it told me that this condition is what is an autoimmune disorder. And then the medication given was the correct one, the potent clobetasol as the treatment of choice. That was the thing which she wanted to know. Now, coming to the good parts, continuing with that, she did tell me the red flag signs. If there are changes in the skin, the ulcer, or some sort of a blister, is going to be an examination. In that examination, she should see us without any delay. However, there was a little sugar-coated way of saying that it can be something sinister. I would definitely name it as a cancer. This is a pre-malignant lesion, so nothing to hide from the patient. Be open and honest. Yes, it can be a risk of a future cancer. Okay. Now, these are all the good points. And on my insisting, Ramya did give me patient information leaflet as well. So all these were the good points in the station. Now let's see points to improve. Vulva is something, if you want to explain that first, Ramya, you can do that by saying that it's the surrounding area around your opening that's around your vagina. We call it as vulva. Then you can use the word vulva. Otherwise, vulva is understandable as well, rather than private parts. Because
Okay.
private parts are more. I mean, private parts like can be anything. It's not only the vulva. Okay.
Okay.
So you can speak as the vulva. Vulva is something which is understandable. If you want to be sure the patient is understanding that, you say that the area around, no, it is not correct. Girija, it's not correct. That's what I've written. Lips is something else. When we say lips, that's labia majora, labia minora.
Okay.
Okay. So when we talk about the lips, for example, there's one station in which the patient is not ready to get examined. So what do you say that, okay, I'm not going to touch you because you're not permitting me to do so. Can you just apart your lips with your own hands?
Okay. Okay.
So apart lips means it's labia. Labia are lips. It is part of vulva, of course, that's the surrounding structure, but specifically lips is the word or the terminology used for the labia. So you have to say the area surrounding the vagina, we call it as vulva. So then you can use the word vulva. Thank you very much, Dr. Sujata. That's perfect. Now, this is what I wanted to just rephrase the private part. Then
Sure.
I told in the last session as well, again, I'm going to say that again. Harshiba, area around the vagina is vulva. Speak it as vulva. Okay? Because genitalia contains clitoris, lots of things are there, right? Why not to be open to the skin surrounding the vagina? that is known as vulva. That's it. Your job is done. Then speak it as vulva. Once you do that, speak it as vulva. Nothing to worry. Okay. Now, I told in the last session as well, I'm going to emphasize upon this as well, that now in exam, we won't say the cervical smear, we're going to say the screening, right? Because we never know it's HPV, we never know it's still smear going on. So let's be safe. Is your screening up to date? Is your cervical screening up to date? In the history of detail, as I think Girija has written there as well, whenever it's something like a skin lesion, always add on one question. Do you find the same complaint anywhere else in your body, at any other skin part of your body? So that clarifies, we have got lots of things like that of dermatitis, like that of eczema, like that of psoriasis. So lots of things are there. So we always need to ask, do you have the same complaint anywhere else in your body part in the skin area? Okay. Now, after this, you need to understand that this is an autoimmune disorder. Very beautifully, Ramya told somewhere in between. But along with diabetes, how do we say, any problem with the raised blood sugar levels or the thyroid levels?
Or other autoimmune problems.
Yeah. So two things at least you have to mention.
Okay.
Okay. Thyroid and diabetes. It's just to add on to this. Now, the third thing is that in any oncology station, you all would always say that, may I know any family history of cancer of neck of the womb, ovaries, or breast? As a rule, family history of concern or significant family history, we would not only say, we would say the significant family history or family history of concern you would like me to know about in all the modules except the oncology. Because in oncology, we need to be sure that we are talking about any predisposition of inheritance, please. Okay, so we would always ask about a name, neck of the womb, breast, or ovaries. After that is done, there was a statement done about the examination. What did I say in the template? And I'm very serious about this because you people take it lightly if it's not a cancer. Had it been C. vulva, I'm sure Ramya would have done the breaking bad news. But for Ramya and for all the students, pre-malignant lesion doesn't come as a breaking bad news. Believe me, it's a breaking bad news. Why is it a breaking bad news? Because it can turn into cancer. This is not something easy for the patient like that of atopic dermatitis. We know that this is the breaking bad news because it can turn into cancer. It can have its predisposition. All right. So you always do the warning shots. I always tell one thing, that keep yourself into that condition. If somebody tells you that this is a pre-malignant lesion, is it a bad news for anyone that just consider yourself being a patient? That it is something which can develop into cancer. Am I right, everyone? Would you all agree? Dr. Sabia, Ramya, Harshipa, Sujata, Girija, Jyoti, always take pre-malignant lesion as a breaking bad news, please. Always do. Okay. That breaking bad news would not be as strong as that of an oncology station, but definitely it would be. I can see, Mary, that you're here alone today. Would you like somebody to be with you? I'm afraid I have a difficult news to discuss with you. That's it. Your job is done. Okay. Now, your examination reveals that there's a condition in which the body's own fighting system starts acting against the healthy tissues. We call it as an autoimmune disease. The findings of your skin, they say that it is a condition, we call it as a lichen sclerosis. You need not tell that it's reddened, it's white. The findings suggest that it's a condition, we call it as lichen sclerosis. I would like to reassure that it's not contagious and cannot spread through the contact, including the sexual intercourse. However, this condition can have severe worsening if not treated. Moreover, less than 5 in 100 women may develop cancer if left untreated. Am I clear about the condition, Mary? So you have to incorporate the pre-malignant element in that situation. That how much is the risk that she can have this cancer into this breaking bad news? This is your open and honest explanation. You will not hide. In the entire station, I could not hear the word cancer. I could hear the word sinister. I could hear the word something serious, so we follow up. I could hear the word that we will do the biopsy, but I could not hear the word that yes, it's a pre-malignant lesion. Am I right, Ramya?
Yes, sir.
Why to hide from the patient? We have to be open and honest. We don't have to see it. It is your duty to clarify the patient that yes, we are going to take measures for this. We are going to have lifelong follow-up for this. You did say that, but I could not understand why. It can be something sinister. So sinister something is not as clarified term as that of a cancer term. Okay, so whatever is the risk, you would always tell with honesty that this is the risk that it can develop into cancer. Now, breaking bad news, please. It's mandatory for all pre-malignant along with that the malignant lesions. Okay, thank you very much. Now, the second thing is that when I said that clobetasol would not work, what did you say? That we are going to take the tissue sample. So anywhere, anything in between, please, all of you. If the clobetasol doesn't work, do we directly do the biopsy? Or do we have one step in between?
We refer them to the vulval clinic.
Correct. But yeah, after that. Tacrolimus. The second step is tacrolimus.
Yeah,
If
tacrolimus.
tacrolimus doesn't work as a second line, then we go to the biopsy. So here the applied clinical knowledge went a little deviating from the normal. Okay, so second step is second line is tacrolimus. If it doesn't work, then yes, the tissue sample is taken. You said that we are going to take a biopsy because to rule out that it might be a sinister cause. So I would be very clear. I would say that if both these medications, they don't work on the patients, we take a small tissue sample for the laboratory study, we call it as biopsy, to rule out any chance of having a cancer. Would that be all right?
Okay.
Okay, so then I would be very clear that if these two, they don't work, then we take a tissue sample. All right, so this is how we work upon this situation. Now, everything was mentioned. You did mention the general and the specific management plan as well, and you beautifully spoke about the clobetasol and how much we have to apply. That was all perfect. Let's see the examiner's key. The only thing here today in the communication with the patient which was lacking was a little fumbling. I mean, you knew what you have to talk, but there were like a little, I would say, or repetition, just because I know that the practice wasn't there. But otherwise, you know how to deal with the situation. It's not something new for you that how to deal with the patient. Patient is feeling sorrowful on something, so you do the acknowledgement. So that was good. You were attentive listener, and please don't forget the BBN. Always make yourself safe. Always do the breaking bad news. Mild BBN for the pre-malignant lesions, and a BBN with strong warning shots in a cancer patient, right? Yeah, I'm coming to that, Dr. Sujata. So the introduction agenda was okay. You did ask about the details of the lesion. One thing which I would like to confirm from this patient in lichen sclerosis is, I know a few of my questions might sound a little personal, but I need to know to formulate a better management plan. May I know, Mary, are you sexually active?
Okay.
So do you have any problem with the sexual intercourse? Why? Because lichen sclerosis is notorious to cause the fusion and adhesions and dyspareunia as well. If yes, then it might, in the management plan, you might have to give some dilators as well. That depends upon the situation. Okay. If it's not there, you'll ignore. But asking about the sexual complaints is important with lichen sclerosis. Okay. That's one thing which I would like to add. So ruling out its autoimmune disease, diabetes and thyroid. Then you did all these histories like gynae, obstetric, medical, family, surgical, drugs, personal, social, and how had she been feeling in the last few weeks. Her main concerns were dealt with. I was happy about that. And I was also happy about one thing, friends, that when I said to Ramia that I went to GP and he gave me this medication, I was doing this with the January batch the other day. They had their oncology session. And because they're newcomers, of course, they are all fresh students who have passed in September. So I, of course, can't compare them with you guys. But at the same time, they're learning how to deal with the patient. But there was a statement which was made that the treatment given to you, please listen to me very carefully. One of my students, she was handling this situation and she said, the treatment which is given to you, that is not the right treatment according to the cause. So we give strong steroid rather than a mild steroid. So the suggestion for this treatment is clobetasol. And then her management plan was correct after this. But I just picked up this sentence of hers, treatment which was given to you is not correct. Is this the right treatment to use in exam? No matter your colleague has given something. Yeah. And I told her very clearly that we have to avoid this. We don't have to blame the colleague. Yes, mistakes that do happen from your colleagues, by yourself as well, but we avoid being very diplomatic in the situation. No undermining at all. Yes, Harshiba, no undermining at all. So Ramya played wisely in this part. She did not mention whatever was taken. She said that yes, that is a mild steroid. At this situation, at this point, we need to give a stronger steroid without mentioning that it was the wrong prescription. Okay, so your safety is that you give the right one today. But what if like anybody has given that? Please don't blame that person for this. That's your patient's safety and your responsibility towards your colleague as well. So that was something good which I liked, and I appreciate that she understood this thing, that she doesn't have to blame a GP for the wrong prescription. She did give me information about the lichen sclerosis. Now, lichen sclerosis, please remember, that is a diagnosis on the typical appearance. So there's some specific management in terms of the clobetasol, and this is a strong steroid which is given for this condition, Mary. Daily, you're going to use that for 1 month, and alternate day for the next 1 month, and twice weekly for the third month. And we are going to review you in 3 months' time. However, if you feel this worsening of the condition, or you feel any change in that vulval skin area, please see us without any delay during this time period as well. If it doesn't work, the team of doctors will sit together and discuss your condition. We've got a specialized drug, we call it as tacrolimus. The duration and the dose of the treatment varies, and the team of doctors, according to your condition at that point in time, are going to discuss with you. If still it's not effective, we are going to take a tissue sample from the affected area for the laboratory study to rule out, if at all, there is some possibility of a cancer. I would suggest, as I told you in the explanation, that this is a condition, if left untreated, can have the risk of developing cancer. Therefore, lifelong self-examination is suggested to these patients. If you see any change, any worsening of the color, any blisters, ulcers, or worsening pain, discharge, please see us without any delay. Along with that, I would like to tell you some general lifestyle modification, self-care, avoiding the irritants, bubble baths, perfume, scents. Moreover, wearing breathable undergarments, that is suggested to help in the management plan, and things and the condition gets better soon. Would that be all right? Thank you very much. Any questions you would like me to answer? Anything which I'm not clear about? So today I'm going to do this prescription for you. You can start this, and if there's no benefit or you see that there's no improvement, you can see us early. Otherwise, we're going to see you in 3 months' time. Would that be all right, Mary? Yeah? Thank you very much. So now I'm clear in the follow-up. If everything goes well, please see us in 3 months' time. If not, you can see us early as well. All right? So please follow the management plan. I am always suggesting the specific first, because the specific management is something important. Important why? Because if the specific management is not done, the time is up. Your applied clinical knowledge goes borderline or failing. General management, you can speak one line. But if you start canceling for the general management, and it takes ample time, and then you have less time for the specific management, the chances are that you might fail. But for the general management, even if you speak one line, that would be all right. Okay, so Dr. Sujata, tacrolimus duration is not something fixed. So that depends upon the situation of the patient. Okay, and MDT decides that how long it can be taken, how much is going to be the duration. So the outline is introduction, agenda, information gathering, explaining the diagnosis, evidence-based management plan, addressing a concerns, mutually agreed plan. Regarding the scoring, the patient safety is fine. Just one word, please. Word cancer, you should be very clear about. Open and honest to the patient. So I'll give you around 1.5. Information gathering, I was happy about information gathering. Just sexual history, take it. I will give you 2 by 2. Communication with the patient, please do breaking bad news. I'll give you 1 for the communication with the patient. Why? Because it's something important to do the breaking bad news. Applied clinical knowledge, I will give you 1.5. Everything was fine. Rest, give a step, the middle step of the tacrolimus. Please don't forget an exam. Okay, so it was a good station. However, it can always be better keeping Ramya in mind. I mean, I know your potential. I know how much you know. The only thing is that the fluency starts getting affected when we don't practice. And I'm sure, as Dr. Sabia is saying, the date would be in front of us. I'm sure it's going to be tedious practicing a station. Right. Thank you very much, my dear. Lovely listening to your voice as always. Thank you. Okay, so any questions regarding lichen sclerosis before we go to Dr. Sujata for the second station?
Yeah, Dr. Sidra, when the
Yes, please.
examination is given, do we say we want to do the speculum examination for the cervix and all? No.
No, no. If it's given to you, you can say that examination has been provided to you, to me, and it says.
Okay.
Okay, so if you want to see that it is something which is not clear from the examination, you can say, I would like to examine you in the presence of a chaperone, and then you tell the examination. Don't say
What
that I would like to reconfirm the findings. Few students, they also say this word that I would like to reconfirm the findings through examination. Then again, it's undermining the your colleague.
Okay.
Simply say that I would like to examine you in the presence of a chaperone. It's okay, it's acceptable. But don't say that because I do not believe that the previous examination would be correct, or I would like to confirm from my side. So avoid these words. Otherwise, you can say, I would like to examine you in the presence of a chaperone. Okay?
How
Right.
to see how the cervix and rest of the womb is? We can say like that?
That would be
No.
a little longer. It's okay that you would like to do the exam because it's already been provided to you, and lichen sclerosis diagnosis is evident. So, I mean, what
Okay.
else do we need to know? Okay?
Sure, sure.
Thank you very much. Thank you. All right. Can we have Dr. Sujata's mic? Please, Dr. Sujata, please check your mic again.
Yeah. Hello.
Yes, you're audible. Friends, Dr. Sujata audible to you guys? Yes? All right. So the 2 minutes start now. And go ahead, Dr. Sujata.
Can I see the first slide?
Sure. Start, please.
Hello, I'm Sujata, and you are? Can I
Mm-mm.
deeply trained
Dr.
in this?
Sujata.
Yeah. This is structured discussion. Okay.
Start, please.
Yeah, I'm Dr. Sujata, one of the candidates for the exam, and I'm ready for the structured discussion.
All right. So how's exam going, Dr. Sujata?
It's going okay.
Okay, that's good to know. All right. So can you please tell me what is your impression about the cervix, and does it look like a cancer to you?
She's a 42-year-old lady who has presented, was missed her appointment for colposcopy, and she's HPV positive, and she has low-grade dyskaryosis on smear. On the examination finding it most probably looks like a cervical erosion.
Mm-hmm.
And maybe or it could be cervicitis, or it could be cervical intraepithelial neoplasia.
I see.
These are my differentials.
So, what are the indications, procedure, and the rationale? I repeat, I need to know the indications, the procedure, and the rationale of each step of colposcopy.
Yeah, the indications for colposcopy are when when you have 3 consecutive inadequate smears, or you have a low-grade dyskaryosis with HPV positive, or a borderline smear with HPV positive, or you get a high-grade dyskaryosis, or a glandular suspicion of a glandular intraepithelial neoplasia. These are the indications for colposcopy.
Okay.
The procedure is it is done as an outpatient procedure. Patient will be the verbal consent is taken from the patient, and she's put on a couch in the lithotomy position, and a speculum is introduced, and the mucus, the cervix is visualized. The entire extent of the cervix is visualized. The mucus is removed with saline first, and then freshly prepared acetic acid is applied to the cervix, so that we have to see the entire transformation zone. It's seen through the colposcope. It will be under magnification, and we should be able to see the transformation zone. And acetic acid is applied for 30 seconds, and if there are any abnormal areas, they will take it up and it will become white. So we call it aceto white areas, because these abnormal areas have a lot of protein in that, and which is coagulated by the acetic acid. Then we'll apply Lugol's iodine, and these areas will not take up the Lugol's iodine. So it will be, instead of mahogany brown, it will be yellow in color, mustard yellow in color.
So the brown area is
the brown area is normal area, and the mustard yellow will be the abnormal area, because the glycogen is used up by the cell, so there will be no staining by the Lugol's iodine.
I see. And the white area is the abnormal one. This is what you mean to say?
Yeah. The white area is the abnormal one, and the yellow area is the abnormal area.
Okay, go ahead. Yeah.
And when you see the abnormal area, we can take a punch biopsy of that abnormal area. And sometimes, if a larger area is seen, we can see and treat also. We can take a loop excision of the entire of that abnormal area. So that can be a treatment as well. And then it is sent for biopsy. And when the biopsy comes, depending on what the result is, the further management will be done. So if it is CIN1, there is no more need for management. She'll be followed up, whether it is CIN1, CIN2, or CIN3. And CIN2 and 3, maybe if leap excision of the transformation legs was not done, we will have to do that. And following up will be, test of cure will be done after 6 months. And then if the smear is negative, then we can do a HPV testing again to see that she is negative, and then a repeat smear after 12 months, and then she will go, if it is normal, she will go on the routine recall.
Sorry, repeat that again, please.
If we have treated CIN1, there is no, we will repeat a smear after 6 months. The test of cure will be after 6 months, CIN1, 2,
test
and
of
3.
Cure is smear?
Yeah, we will do a smear first, and then we will do a HPV as well.
Okay, so if it's normal after 6 months, then?
After that, after 12 months, it will be repeated again. The smear and the HPV, and if it is negative, then she will go on the routine recall.
Routine recall means 3 years or 5 years according to the age.
Every 3 years according to the age.
Okay, all right. Okay, yes, please go ahead.
That's all I can rationale of each step of colposcopy. If
Okay.
it is,
Yes.
if then I need to know about her history. Like if it is more than if it is carcinoma in situ, then I need to know about her fertility desires. If she wants more children, then up till if it is invasive cancer, up till 1A, 1B1, I can do offer her trachelectomy and
All right. So please tell me what to do if the biopsy report you have done through the colposcopy and it's normal. When to repeat the colposcopy?
the biopsy is normal, then we will repeat the smear after 6 months. That's what I know.
Why we test for HPV and can HPV be eradicated?
HPV is a virus which is responsible for around 99% of the cancers of cervix. So, and usually it affects women who are sexually active, men and women who are sexually active. And due to the body's immunity, the infection usually regresses by itself in 85% of the women. In 15%, when the immunity is depressed, it can persist. And when it persists, it can affect on the cells of the transformation zone, and it can cause the changes which will lead to cancer cervix over a period of time.
So
So
what is the role of HPV vaccine then?
yeah,
And the
so
importance of cervical screening, please.
yeah, so HPV vaccine has been instituted by the NHS so that women, boys and girls will be protected against the effects of the HPV virus in causing cancers,
Mm-hmm.
especially in women. In the school children between the ages of 12 and 13, the first dose is given, and then the second dose is repeated after 6 to 12 months. But if they missed it out at that time, after 15 years, they will need to take 3 doses, one at 0, 1, and 6 months. So this gives them protection against most of the cervical cancers. And now quadrivalent vaccine is given, which protects against the high risk HPV viruses, especially 16 and 18. And but even if they take the vaccine, they have to be screened from 25 years of age to see how the smears are and how the cervix is. So they will be put on the regular screening schedule of every 3 years from 25 years till 49 years, and after 50 years they will be every 5 years. So they will have to do the screening. So that is the importance. That's the role of
All right.
HPV.
So what is ectropion? What are its causes? And explain the treatment of chronic cervicitis, please.
Yeah, ectropion is when the columnar cells of the endocervix proliferate and come over onto the squamous epithelium of the ectocervix. That usually happens when the estrogen is more, when you take oral contraceptive pills during pregnancy. So, or when the level of estrogen is high. So these are the causes of ectropion. Usually it disappears by itself. And the treatment of chronic cervicitis, we have to take a swab to see what is the cause, whether it is candidiasis or any other infection, and treat accordingly.
Bell rings.
Hello.
Yeah, the bell rings. What do you say?
Thank you for the time.
Okay, thank you very much. How was the station?
I didn't. I just saw the structured discussion, then I saw a colleague, so I thought.
Always see. First thing which I taught you guys in the first session was that please, the first thing you have to see is that is it an SPT or is it a structured discussion? So that's the first thing you have to see, right? So when you said that, hi, I'm Dr. Sujata, one of the doctors, so you are, and I was like, oh, what's going on here? I'm an examiner here, Dr. Sujata. So I had to say at that time, hi, Dr. Sujata, I'm your examiner. This is a structured discussions. So I said, okay, let's go to the first slide. You need to see that. Yes, Jyoti, Dr. Sujata is full of knowledge as always. I see her in that group. Dr. Sujata, what is that group where there's one person who is doing the cases discussion? Yeah. So I always see that, yes, you're full of expert advices there. You know, at times I feel like jumping in, then I'm like, oh no, Dr. Sujata is here and she's full of her suggestions and full of expert advice. Definitely experience that speaks a lot. And thank you very much. But one thing which I would like to ask is that honestly tell me that have you gone through the new HPV?
Yeah, I learned. I went through it, but I think I got little confused. I
So no, Jyoti, that's not ours. That's some persons where the case discussions are done generally. That's not our group. So that's an open group of made by some, I think, Sudani doctor or something. So Dr. Sujata is active there. Okay, so Girija, please tell me that Dr. Sujata, when she said about the follow-up, was it the new follow-up after 6 months, the treatment, and was it the older one which Dr. Sujata was saying? Yeah, so we don't do the smear first. Now it is the HPV trial. Test of cure is not smear, it's HPV. All
Yeah,
right?
it's only high risk HPV that we do, and only if it is
Exactly.
positive, we will do the
HPV. That's the
cytology.
difference. That's the reason I brought this station for. So impression about the cervix, it is an unhealthy cervix showing erosions. You were very clear about this word. Cervical ectropion can be the differential cervicitis. It can be a pre-malignant lesions like cervical intraepithelial neoplasia or the cancer. As she is high-risk HPV positive with a low-grade dyskaryosis, so she needs a colposcopic biopsy to confirm. Now, the indications of colposcopy, we have got two pathways, a 2-week pathway and a 6-week referral pathway. If there's a suspicion of an invasion, high-grade dyskaryosis, the glandular neoplasia, or the borderline changes in the endocervical cells, it is 2-week wait pathway for the colposcopy to be done. However, if there's no evidence of cancer, it's a low-grade dyskaryosis or the borderline changes in the squamous cells, or it's a persistent high-risk HPV positive after 2 consecutive 1-year waiting. And if there is an persistently inadequate samples, it's going to be colposcopy, but that would be in 6 weeks' time. So please tell me that what would be the condition here? Her colposcopy would be in 2 weeks or 6 weeks?
18 weeks.
This is 18 weeks, a wait pathway, which is the longer one. They clearly say in the guideline, this is copy paste from the guideline, please, that it is 6 weeks of referral in 99% of the cases. So you would speak it as 6 weeks referral. Okay, 6 weeks referral. Very well done. Okay, so coming to the procedure, explain the procedure to the women, and I would give the written information regarding colposcopy. Informed consent would be taken as a second step, written consent with all the details of the procedure and anticipated complications. Rule out comorbidities, specifically allergy to the iodine and use of contraception, any history of sexually transmitted disease, and rule out pregnancy as well. The first step would be the insertion of the vaginal speculum and inspection of the cervix in a relaxed lithotomy position. Lubrication of the speculum would be done. Look for any ectropion, polyp, Nabothian follicles, congenital transformation zone, atrophy, inflammation, infection, some hypokeratosis, condylometallatta, some ulcer growth, or any obvious lesion in vaginal cornices just after insertion of the speculum. Now, obtaining of the cervical cytology smear, if it's not done earlier, it will be part of the colposcopy step, and obtain specimen for the laboratory examination if necessary, like gonorrhea or chlamydia, if the history of vaginal discharge or sexually transmitted infection contact tracing is done. Applying acetic acid, we call it as VIA, visual inspection with acetic acid. And you were absolutely right, the cells which pick up the acetic acid, they turn white, and these are the abnormal cells from which we have to take the sample, the biopsy. Lugol's iodine solution, we call it as VILI, the visual inspection with Lugol's iodine. The brown and the black staining is normal. I tried to confuse you there, but you were pretty confident. The precancerous lesions, they are yellow. So for acetic acid, white are the abnormal one. In the Lugol's iodine solution, yellow are the abnormal one. And then consent with all details of the procedure and anticipated complications, that's taken because now we need to take the cervical biopsy from the abnormal area. If endocervical curettage is part of the procedure, would be done. If not, this step would be skipped. Inspect the vaginal walls, the vulva, perineum, and the perianal areas as well. Then the bimanual and rectal examination would be performed. Explanation of the findings to the women and the documentation in detail. This was the answer. If it's a normal biopsy, when to repeat the colposcopy, please? There are two answers to this as per the newer algorithm. They say that if the colposcopy has an adequate result and she has low-grade dyskaryosis with high-risk HPV positive, it would be a recall in 36 months. That means 3 years. It's not a routine recall. For any age, it's a recall in 36 months. If the sample is adequate with high-risk HPV positive and high-grade dyskaryosis, but no sin is found in the biopsy, right, it would be discussion at MDT in 2 months' time. From where I'm talking about this, I'll just show you in a bit in the algorithm, okay? Testing for HPV and HPV eradication, it's the most common STD and it can be transmitted through skin-to-skin contact, the vaginal, anal, or the oral sex, and the sharing sex toys as well. So the eradication can be with condoms, the barrier method, and the vaccination. 2 types of vaccination are available. The Cervarix, the bivalent one, which protects against HPV 16-18. Intramuscular in deltoid 0-1 at 6 months, 0.5 ml is given. The quadrivalent is the Gardasil that protects against HPV 6-11, 16-18. Bivalent is safe and it does have its cross protection. However, Gardasil is used commonly because of the wide protection against the HPV strains. Now I need your attention, please. This is number 1 algorithm, which I want all of you to do. The difference is that now we are starting from HPV. Are you all with me? Do you want to read this algorithm or shall I skip them? You can do yourself. All of you, please. I'm okay both ways because I teach them in part 2 as well. No problem for me, but I want you to know this because now if the station would come, that would be from the newer one. Okay? Yeah? Okay. I'll do that. The first thing, I need your attention then, okay? No multitasking, please. Yeah. The first thing is that now it's going to be high-risk HPV test for the first step of the cervical screening. It would not be cytology. The first thing you need to understand is that if HPV is negative, we do not do any other investigation, please. No smear at all, Dr. Sujata. If HPV is negative, it would be a routine recall. That is 3 years and 5 years according to the age. Please tell me 3 years till what age? 3 years till what age?
49.
49. From 50, as it's a 5, so from 50, because it starts from 5, we shift the patient to a 5-year routine recall. So routine recall means if it's negative, she'll be coming according to the 3-year or 5-year time according to her age. The second result in the screening can be HPV positive. Now would be the step. Any patient who is having high risk HPV positive is a step where we do the cytology now. If the cytology is abnormal anywhere, abnormal means either SIN1, SIN2, SIN3. If cytology is abnormal, it is going to be a colposcopy referral. However, this colposcopy referral can be in 2 weeks, can be in 6 weeks, according to the reason why we are sending for colposcopy, please. Okay. Now you have done an HPV. on a patient who has come for a routine screening and HPV is positive and the cytology is negative. If it's negative, you won't take any step. Because HPV is positive and cytology is negative, you will give her 1 year time, and after 1 year, you will repeat the HPV. If after 1 year, the HPV turns back to negative, you're happy about the patient, right? So you are going to send her again on routine recall. Forget that 1 year back she was positive, because now she has turned negative. Your job is done. Giving her 1 year, the HPV is washed out. Okay?
Yeah.
So HPV is negative, you go to the routine recall. But after 12 months, if it's a second HPV positive, first was positive 1 year back, after 1 year, it's again positive, you do the cytology again. If it's now abnormal, you will do a colposcopy referral as a rule. But if it is HPV positive, but again after 1 year, the cytology is negative, the guideline says that please give her another 1 year. In other words, HPV was positive, cytology was negative, you gave her first 1 year. Again, after 1 year, HPV was positive, cytology was negative. You gave another 1 year. So in total, you give her 2 years time being HPV positive and cytology negative.
Okay.
If the patient stays HPV positive for 2 years, and even now after 2 years, the cytology is negative, the guideline says persistent HPV positive for 2 years' time, despite the cytology now is negative, inadequate, or abnormal. Whatever the cytology is, now this is an indication of colposcopy referral, and this is only updated in NHS CSP Cervical Screening Program 2020. This wasn't ever in the older guideline. Could I clarify to you guys that how the stepwise management would be? Why am I emphasizing on this? Because in January, there were 2 questions from this algorithm. That means what? That college is having inclination towards this. Okay. Could I clarify the first algorithm to you guys? Yeah?
Yes.
Right? Okay, one more thing I would like to say is that I asked this question in the EMQ and in the mock, and students had difficulty in answering it. 100% of the students, they make it incorrect. I'm going to ask that for you guys. I know I'm deviating, but this is something because, see, everybody is facing difficulty. Now the RCPI and cervical check is changed as well. Irish guidelines are changed to the HPV as well. Now they are also doing the HPV testing. They're not doing smear. So both in United Kingdom and Ireland, they have shifted to HPV. Okay. Now the second thing which I would like to tell all of you is I'm going to ask a question. I won't answer. Okay. A patient is HPV positive. A patient is HPV positive, and being HPV positive, she has had cytology negative. After 1 year, again, she was HPV positive and cytology negative. So now again, 1 year was given. After 2 years, she is HPV positive. So 2 years, high risk HPV positive. What would be the next step?
Colposcopy referral.
Yes, please. I want answer from everyone. What would be the next step?
Colposcopy.
100%?
Yes.
I said that 100% people, they answered it wrong in the mock, and this was the answer they gave. Thank you very much, Dua. Dua is the only person who is making the correct answer. As a rule, whenever HPV comes out to be positive, next step is smear. No matter whatsoever would be the result of smear, colposcopy would be done. But we never skip the smear part. Okay. What is the reason behind that? I said clearly, I wrote in EMQ, what is the next step? And they all wrote colposcopy. Why? See, there's a difference. And students, they ask me, ma'am, why would we do the smear when we have to do colposcopy? And I give them just one statement. Please tell me. Girija is the colposcopist and she has got 2 patients. One patient is high risk HPV positive for 2 years, right? And her cytology is negative. And the other is high risk HPV positive for 2 years. And this time his cytology reveals high grade dyskaryosis. Is there any difference between severity or the intensity of both the patients, please?
Yes.
Yes.
Do you people understand? A colposcopist needs to know what is the smear, what is the standing of the patient, so that while doing the colposcopy, they know that where they'd have to see. What is the severity? In both the cases, because they are persistently HPV positive for 2 years, we are definitely going to take the colposcopy as a step, an ultimate step. However, the next step is always smear, because smear tells us the severity of the condition. Am I clear, everyone?
Yes.
Yeah? Okay, thank you very much. So if I rephrase that question, please, I know you people have passed your part 2. That's not important for you, but just to analyze that I've understood that you people are getting the absorbing the new cervical screening. If I say that the patient, she had 2 persistent HPV positive in 2 years time, and again, her HPV is positive in after 2 years gap, what would be the definitive management? I'm not asking about the next step this time.
Colposcopy.
Thank you very much. Do you people understand the difference? Okay. So the first step is always doing the cytology, or the next step, but definitive is colposcopy for them. Thank you very much. So 24
So
to
Dr.
49.
Sidra, even
Yes,
here, if the smear, would it decide the time frame for the colposcopy, like whether it is 2 weeks or 6 weeks?
no, I'll
Okay.
go back. I'll tell you why. I'm going back. I'll tell you why. This is copy paste from the new guideline. Can you see here? Persistent high risk HPV positive.
Okay, so that
Okay.
comes under
That comes
6
under
weeks.
6 weeks time.
Okay,
Now
okay.
there's a reason for this, provided it's not high grade. If it would be high grade dyskaryosis, it would go there. So otherwise, if it's a cytology negative, if it's a cytology low grade, it would stay in 6 weeks time. Okay. This is
Okay.
persistent high risk HPV positive. The only difference, yes, if it would be high grade dyskaryosis, then it has to be done in 2 weeks time, because the smear is high grade. Okay. All right.
Thank you.
Now, no problem, my dear.
Dr.
All good there.
Sidra, Dr.
Yes.
Sidra, what about the HPV test? If it comes out low risk, is there any change in protocol? Do we repeat the HPV in 3 years or 1 year? What do we do if
Low
it
grade
comes out
what?
to be low risk
Seriously?
HPV instead of high risk, low risk HPV?
No, we don't pick it up. We only see the high risk HPV as the standard for the follow-up. We test only for high risk. We call it as HR HPV test because these are the strains which are important. Okay. Only high risk HPV strains are picked up. And that's the reason, because we follow only high risk.
And the routine recall that we are doing over here, when HR HPV is positive and the smear is negative, after one, I mean, if we go back to the routine recall, we are doing it with HR HPV itself.
Always. That's what I wanted
3
to.
years
I
and 5
asked
years.
twice Dr. Sujata. She said smear. We never do first test as smear now. It's always HPV as a first test. Smear would only be done now in UK if high risk HPV is positive, my dear. That's it. If it's negative, we never do the smear. We go ahead with the routine recall, and next time again, high risk HPV.
Okay.
Thank you. Why am I explaining to you guys? Because I know that you all of you are the ones who have done your part 2 way too earlier. Because my newer students for the last September exam and the January exam, they've done their new cervical screening, so they don't have a problem. You guys do have a problem because now it's a shifting because of a delay in the exam. Now the new cervical screening would be there. Okay.
Dr. Sidra, can you please share the new guidelines? I can't remember. On the
that is
group.
in your Google Drive as well, my dear.
Okay.
The Google Drive.
I'll look it up.
I've updated all the new talks, and all the recent NHS cervical screening is there. The new one.
Okay.
If you don't find it,
thank you.
Okay, I'll update that. Okay.
Okay, thank you. Yeah.
So 3 years, 25 to 49 years, and 5 years, I make my students memorize it at like 550. So 50 is starting from 5. So from 50 years, we make it 5 years. Okay. This was the older one, which you people used to do, which you don't have to do now. Okay. So this is from where I asked Dr. Sujata the question from. Are you people aware of this algorithm? Because that's different from that of the older algorithm. Would you like to do with me, or can skip, because that's not related to the session, but I placed this because I know that you people have done the older ones. So you should be knowing about this one as well. If you people have time, I can do that for you guys. Yeah. I would not read it. I would make you learn it. Yeah, Harshiva? All right. Yes, Dr. Sabia, please get ready for the new algorithm, all of you. Yeah, thank you. So now this is an algorithm in which we have started the colposcopy. Okay. Now the colposcopy indications are in the previous algorithm. Now this is a patient for whom we are having a colposcopy. Why? The colposcopy examination would be either she was HPV positive, please listen to me carefully, either she had HPV positive, and because of being HPV positive, this patient had her smear abnormal. So when I say smear abnormal, it can be mild dyskaryosis, it can be severe dyskaryosis. Okay, no problem. I'm here, Dr. Sabia. You know me from part 2, yeah? That's my responsibility. Please don't worry. And colposcopy examination, and please don't worry. If anything new comes, any guideline new comes, I'm starting my APCOG sessions are started from yesterday. MRCOG sessions are going on side by side. If any new topic you people are worried about till your exam, any update in the guideline, I will send you that live sessions link, okay? So that you can join those topics. If at all some new topics come, please don't worry about. I'm going to cover that if some updated guidelines are there. All right. So just drop in the group. What I'll do is that whenever I'll be taking those updated topics for the part 2 people, I'll add you people there. Okay. I'll send the link so that you can join. It's a big class of 250 in the part 2, but still I'll send you the link so that you people can join the class if new topics would be there. I would definitely, I know that it's been a gap, Dr. Sabia. The things which I taught you now, they're outdated. In fact, my oncology, everything is now, the entire session is changed because I've updated them according to whatever the newer guidelines are saying. Okay, definitely. Whenever you people have any doubt or any updated guideline, please, I'm all there to guide you guys. Don't worry, please. Okay, so the colposcopy examination would be if the patient has HPV positive, listen to me carefully, and she had an abnormal smear. So the colposcopy examination can either be inadequate or it can be adequate. The inadequate, they say in the guideline that colposcopist cannot comment upon the findings. That is an inadequate colposcopy examination. An adequate colposcopy examination is when the colposcopist can comment upon the findings. Okay, now this depends upon the type of the findings, please. If it's an inadequate colposcopy examination and it was done because we had an HPV positive, right? And the positive cytology was there. High risk HPV was positive and it was a low grade cytology. I repeat that again. A patient is with you for colposcopy because her HPV is positive, high risk HPV is positive, follow the laser pointer please, and she has low grade cytology. For this reason, this block is the reason of colposcopy. For this reason, she had an inadequate colposcopy examination when colposcopy was being done. Please give her 12 months time, 1 year time, and after 1 year, still if it's going to be inadequate colposcopy, then you might consider doing the large loop excision of the transformation zone or give the patient choice if she wants to wait another 1 year. So in other words, for which group of people we are waiting 1 year? The ones who had high risk HPV positive and their cytology was low grade, that made us decide that we have to do colposcopy, and the colposcopy was inadequate. We are not taking an aggressive management for these patients. It is inadequate. Give her 1 year time and redo the colposcopy. This 1 year, after 1 year, Jyoti, this would not be high risk HPV because we stopped at inadequate colposcopy. So after 1 year, we are doing colposcopy to see that now it's an adequate finding and we detect what is the problem. Do people understand this part, please? Is the A part clear to you guys? If yes, let me know. I'll move further. Yeah, is it clear that we are giving her 1 year because it's inadequate colposcopy, and after 1 year, we are doing the colposcopy. Now, the second inadequate result, if the index case, we did the colposcopy because high risk HPV was positive. High risk HPV was positive, but cytology was high grade. Remember, high grade cytology or borderline endocervical is taken to be high grade. In NHS 2020, they've converted borderline endocervical into the high grade and borderline squamous cells comes into the low grade, please. Keep a note. If they give you that cytology is borderline endocervical or it's high grade and high risk HPV is positive, that would be the case that no matter it is an inadequate colposcopy, we are done the colposcopy for this patient. No matter it's inadequate colposcopy, we will not wait for 1 year. We will treat this patient directly without waiting for 1 year because it's a high grade cytology, no matter it's inadequate colposcopy. We would not wait further. Do the LETs at that time, no matter it's inadequate. Now, the other part is that we are doing a colposcopy for the same patients, but it is adequate. The adequate colposcopy means that we have a result for the colposcopy. What does the colposcopy say, right? The colposcopy is done. Please follow this block first and follow my laser pointer because it's up and down in this part. Now, if it's a colposcopy done for a case which had high-risk HPV positive and the cytology was low grade. So this is the same case like that of here. High-risk HPV positive and the cytology was low grade. And when we did the colposcopy, it was adequate this time. The colposcopy was adequate. However, the colposcopy revealed a normal finding. The investigations showed HR, HPV positive and cytology low grade, but adequate colposcopy that showed that there is no impression of sin, that there is a disparity between the findings on the smear and the findings of the colposcopy. Colposcopy is normal. So we are comfortable after the colposcopy. Shift this patient, call her after 3 years. It's not a routine recall, please. It is a recall in 3 years, no matter she's more than 50, no matter she's less than 50. She has to be called in 3 years. However, if it was high-risk HPV positive and the cytology was high grade, now the colposcopy is normal. Now we are really worried. We are not comfortable about this patient. Why? Because it was high-grade changes on the smear. HPV was positive, but the colposcopy is normal. Now MDT would decide that within 2 months, do we need to do LETs or do we need to spare this patient or leave this patient for follow-up? Because it's a high disparity between the findings of the colposcopy and the initial testing. In other words, in this scenario, the case which Dr. Sujata was solving was a mild dyskaryosis. High-risk HPV was positive first and mild dyskaryosis. And I said that when would the colposcopy be done? So if the answer was, if the colposcopy this time is inadequate, we are going to repeat the colposcopy in 1 year time. And after 1 year, if it's the same finding, LETs can be considered. If the colposcopy examination this time is adequate and it is normal, then we'll call this patient for HPV in 3 years' time. So this was the case. Block this and block this. This was the case which I asked in the question. Am I clear, everyone? Am I clear, everyone? Yeah? Thank you very much. Thank you. So it depends upon adequate findings or inadequate findings. And according to that, you're going to see, right? Thank you very much. I'm really grateful. So don't worry about this algorithm. This is the only algorithm which is same as that of earlier. SIN1 untreated is the same. SIN2 treated is the same. And CGIN treated is the same. These are 3 algorithms which are given in the older guideline, and they are the same. I do mark it for the newer students because these are certain EMQs which come from this. In December, RCOG online course, they did give some questions from this. So for part 2 students, I go into detail. For you guys, this is the same as untreated in 12 months, treated in 6 months time, and CGIN in 6 months time as well. The only thing which you need to understand is that please remember that whenever the patient is being followed after 12 months or 6 months or 6 months, in this case of SIN1, SIN2 or CGIN, it has to be HPV. Okay, so first test is always HPV. Please keep a note. The last question was cervical ectropion. What is that? It's a harmless change. It's related to the estrogen and more common in the young women, the pregnant women and those taking the combined pill. So 3 P's are there. What are 3 P's? Puberty, pregnancy, and pills. Okay, so it may cause increased vaginal discharge, can be treated with cautery. The chronic cervicitis can be treated with cautery or diathermy under local anesthetic. And for cervicitis, not caused by infections, there's usually no treatment and they settle down when the cause is removed. So this was the second station. Sorry, I took time, but I wanted to cover this important element because I know when reading alone, this tends to mess up, but when we are reading together, it tends to become easier. Thank you very much, Dr. Sujata, for volunteering for Dr. Bindu. I'm really grateful. Thank you very much. Thank you. All right. So let's go to the station number 3. And yes, my dear, I'm
Doctor,
open to the questions. Yes, Dr. Sujata, please.
Yeah.
Jyoti, your
yeah,
turn.
thank you so much for the opportunity. I learned a lot today.
I'm really grateful. I'm really grateful. I'm always with you guys. No matter the live sessions are ending, I would like you all to be quick, and I would always be there to answer your queries and take you through the exam. Okay, nothing to worry, please. All right. So station number 3, please. Can we have Jyoti here? Hello, Jyoti.
I am here, but I have a question regarding the previous.
Sure, please. Yes.
Can you please go to the answer of question number 3?
Okay. Let me pause the screen so that I can quickly go.
I can ask at the end as well, whatever is.
No,
Okay.
it's okay. It's okay. I'll go. Yes, please. Can you see the screen, all of you?
Yes.
Yes, my dear.
No, question number 3.
Yeah, question number 3, my dear. If normal biopsy went to repeat colposcopy, right?
Well, if inadequate and HR-HPV positive with low-grade dyskaryosis, is it recall or is we call them after 12 months?
That would be 12 months if it's inadequate, right?
Yeah.
And 36 months if it's going to be normal.
Yeah, so it says
I'll change that.
inadequate.
Yeah, I will correct that. It is just follow this one. I'll tell you.
Okay.
Let me tell you.
Thank you. Just wanted to clarify that.
Just follow this. Adequate.
Yeah, got it.
Yeah. If adequate, follow this 36 months. If inadequate, follow in 12 months time.
12 months,
Okay.
right.
I'll correct that IN thing for you.
Okay.
Okay. All right. Thank you very much. All right. So are you ready for the station? Oopsie, sorry. I hope you've not seen the question. All right. So let's go to this. And can you see the screen? Jyoti, 2 minutes start. Hello, Jyoti. Jyoti. Jyoti.
See only station number 3. I can't see anything else.
Yeah, I'm starting at 2 minutes now. I was waiting for the thumbs up. Yes, go ahead.
Next slide, please.
Sure.
Can't see.
Can you?
No.
Friends, can you see the candidate instructions, please?
No.
Anybody in the chat box, please confirm me.
Yeah,
Yes, it's visible. Jyoti.
Now we can see.
Okay, go ahead.
Oh God, this is the only station which was like I hadn't touched. Next slide, please. Okay.
Start.
Hi, I'm Dr. Singh, one of the doctors in the clinic today. May I confirm your name and age, please?
Hello, doctor. Doctor, I'm Camila Poor. I'm 57 years.
And how do you want me to address you?
Camila is okay.
Camila, I understand that you're here today because you had some episodes of postmenopausal bleeding, and your GP has written to me saying that he or she wanted me to review you. Is that correct?
Yeah. Yes, doctor. I'm really worried about that.
Yes, Camila, I understand your concern, and yeah, it's natural for you to be worried. So in the next few minutes, I'm going to talk about it and get a couple of questions, have a couple of questions, understand your condition. Then I will answer your concerns, I'll review you, and if needed, I would examine you. Is that all right?
It's okay.
So Camila, can you tell me more about what you're having?
It's been a long journey, doctor. I was diagnosed with breast cancer around 6 months back, and they
Yeah.
did surgery to me. They removed the breasts, and following that, they placed me on tamoxifen. And they did tell me that this is something which is for the treatment, and I was really happy a month back that now the treatment is successful, and they said that the cancer is cured. And I had been through a tough time in the last 6 months in terms of the treatment. That was really difficult for me, going through some psychological uh, difficulties, and of course dealing with the situation. I was very happy in the last 1 month that now at least I'm out of that difficult situation, and now I'm going to live again. And just suddenly I felt that I was having some sort of a spotting, and I talked to the GP for this, and 2 days, with the 2 days gap, I had another bleed. And that was to an extent that I had to wear my sanitary napkins. I mean, it was not only spotting, the second time it was a bleeding. So he told me that this is something really serious. I mean, there can be some underlying cancer. And I was like, I cannot sleep since then. I don't know. I just want to stop this medicine. I cannot afford to have another cancer. Please help me out with this.
I'm really sorry, Camila, to hear about the condition you are in, and I agree it must have been really, really tough for you. Um, However, as they said, the breast cancer was cured. That is a good thing. And of course, we are going to investigate what has been happening now. But I really, I'm here to help and support you and to do whatever treatment is possible for you and whatever way I can help you. Is that okay? Do you want some water?
No, it's okay. It's okay. Please go ahead. Yeah.
Okay. So, may I know when did you have the cancer? Sorry to bring you back the memories of those
6 months
tough
back,
times.
doctor. 6 months back, I told
6 months. And since how long are you on tamoxifen?
you. It's been around 4.5 months. Yeah.
Okay. Apart from these two episodes, any other episodes of bleeding?
No.
Okay. And how were your periods before?
I mean, before menopause. Yeah.
Yes, before
Yeah, that
menopause.
was all right. Yeah.
And how is your smear history?
Yeah, my cervical screening is
I
going
mean,
on.
the cervical screening, is
Yeah.
that all right?
Yeah.
Was that all right?
Yeah.
Um, and any history of taking contraceptives in the past?
Mm, yeah, I used to practice condoms.
Okay.
Mm,
Any other medical conditions that you have, Camila?
and now I'm otherwise a fine doctor.
Any other surgeries in the past apart from your breast surgery?
Oh, yeah, I've got 2 kids, both were cesareans, doctor.
Okay. And okay. And any other history in the family of any other illnesses, especially of cancer?
Not that I know of.
Okay. And any other medication apart from tamoxifen?
Some tonics they gave me just for good appetite and all. That's it.
Okay. So are you able to eat well now?
Yeah, it's better. Yeah.
Okay. And any allergies to any medication?
No, doctor.
Any And who do you live with, Camila?
I live with
Is
my
there,
partner, my 2 kids. We all live together.
is there good support at home?
Yeah, yeah.
Okay. Do you smoke at all or take
Mm,
alcohol?
No, doctor, can't afford to.
Sorry. And what about your occupation? Do you work?
Yeah, I had been working. I was working in a as a customer service in a shop, but actually, just after this diagnosis, it's been around 8 months that I've left that.
Mm-hmm.
Yeah,
Okay. Okay. Are you happy being at home or resting, or
it's
are you?
okay. I think my health requires attention.
Yes, exactly. And you did tell me that you were anxious and you had a lot of anxiety, as well as you did feel a little down when you were going through all this.
Yeah.
How is it now? Is it
I
any
mean, the
better?
previous thing, I was really happy that I've coped with it now and it's over. But now this new thing, this bleeding, that's really making me upset.
Okay, we'll sort that out, Camila. So, and what is your BMI? Do you know your height to weight ratio?
That's 25.
Okay. Um, so have you thought of reducing your weight?
25? No, I think it's okay. No,
Okay, do you think we can help you to reduce weight, because it can reduce a lot of problems?
it's 25, doctor. You think it's a
Okay, it's 25, all right, fine. So that's fine then. And okay, so thank you for answering all my questions, and so promptly. Um, will I be able to, is it okay if I examine you now in the presence of a chaperone?
That's fine.
Okay, so I have your ultrasound findings. I have read your name on the ultrasound, and I have seen that it is yours. It carries your NHS number and your name. So it shows that you have the lining of the womb is 7 millimeter. Okay.
Mm-hmm.
Uh, I think it's normal for a person who's on tamoxifen uh, to be having endometrial lining thickness of 7 millimeter.
That's a relief, doctor. Thank you very much.
But I'm going to examine you and find out if there's any other reason. I'll have a look inside to see if there is any lesions inside your, outside the cervix or in the vagina that is causing this bleeding. And I would also examine to see if there are any palpable masses, like if I can feel anything through your tummy. Okay.
Okay.
And I think that is all right. So I have a TVS scan which is showing a 7 millimeter. I would like to do a few further tests, which will include taking a sample from inside your womb. Will that be all right for you?
How would that be taken? And moreover, when the lining is fine, I mean, that's reassuring. Why would you like to take it?
So 7 millimeter is definitely below, I mean, within the cutoff. But if you were not on tamoxifen, I would expect it to be less than 5 millimeter. So just to make sure of things, and just to be sure that there is no other sinister findings.
Okay, so how would you like to take it? I mean, it's going to be just here with a.
Okay, sorry. Okay, so there can be two ways by which we take it, either as an outpatient, giving you some painkillers, and or as an inpatient. Inpatient, which means under general anesthesia, putting you to sleep. And then we take some tissue out of this lining, send it for seeing under the microscope. And then if the findings are fine, we convey back to you, and I will always also write back to your GP.
Outpatient ones, that means that it's just going to be a simple tube and you're going to take it with that?
If it's an outpatient, we'll give you some painkillers. I'll explain the procedure to you. I'll take your consent, and I'm going to put a small tube-like thing, a tiny one, inside, and that is called an endometrial papille, and we take a biopsy from there. However, I can also do something called hysteroscopy, which means taking a look inside your womb and then taking the sample from there. Both can be done as outpatient, means you come and then we do the procedure and you can go back home. The other way we can do it is if you're scared of the pain, or if you're not okay, if you think you'll be anxious, we can take you to a theater, put you to sleep.
No, it's okay, doctor. My threshold for pain now is so much higher. I think I can manage the outpatient, doctor.
Okay, so I'll give you some information leaflet on
Sure.
that, and we'll fix an appointment for that. I'll write back to your GP, and then I will arrange for the further things. Once the reports are back, I'll write back to you and then go ahead with whatever the findings are. We might need to involve a team of doctors to give us expert opinion on if we find something abnormal there. Is there any other questions that you would like to ask, or
No,
anything?
okay, doctor. I'm really relieved talking to you. Thank you very much.
Okay, and if you have any questions at any point of time, you can contact us at this number. I'm giving you a number here.
Thank you very much. Thank you, doctor.
Thank you.
All right. Thank you very much. How did the station go? Tell me.
Poor time management as always. No practice, and I wasn't sure about the 7mm, though I did.
But you were so confident in telling me. There would have been a diplomatic way somewhere, midway of saying things as well, no?
So patient, I think when tamoxifen is there, it is 8mm, isn't it? The cutoff.
That's more than 7mm, but there's a problem here that she's symptomatic. So the talk article says something else. What does the talk say? Girija, no matter it's less, no matter it's more, it doesn't matter in this patient at all.
For symptomatic, we always go for hysteroscopy and directed biopsies.
Thank
right?
you very much. So unfortunately, they were fortunately there were very good points in the station.
I realized that it is not papille.
To be done, yes. And I was repeatedly asking for this reason that I asked for a tube, and you say that we won't go for that. We need to visualize with the camera.
No, so I said we'll have a look. Something
No,
called
that was as a second option, like after telling papal. Papal is no option in a tamoxifen patient.
I exactly know. After telling that, I realized that it is not.
I wanted to trap you, and you were trapped in that situation. So there were many good points in the station. However, the applied clinical knowledge and the patient safety, both they went towards failing. Reason was that tamoxifen patient, you never go for this. And secondarily, did you feel that I was a little reassured by your ultrasound? It is not reassuring. Ultrasound doesn't matter if the patient is symptomatic. It doesn't matter because there can be underlying cancer. Yes, if a patient is asymptomatic and incidentally we see more than 7mm, that's a cutoff for hysteroscopic biopsy. But any patient who is symptomatic, they say, then the ultrasound findings of the endometrial lining, that doesn't matter at all.
That's exactly why I did the hysteroscopy.
Yeah, and that's the reason you did hysteroscopy. But as a patient, the feeling I got that you have got a normal endometrial lining, however, you could have, continued with that. However, yes, you're right. See, it can be an underlying cancer. High risk patient she is. So we don't have to give her false reassurance here. How I'm going to tell all about this, I'll just tell you in a bit that what the findings would be, how we are going to take care of the situation. Okay, let's go to the good things first. So, Jyoti, I was happy with your introduction. I was happy with your rapport building with Camila. And you asked about the postmenopausal bleeding, her concerns. You had an open question of information gathering. All these points are good. I'm sorry you have been through a tough time. So we are here for the support. All that was good. So the investigations help support personal cervical screening, medical history, surgical, family, cesarean sections, cancer history in the family, and allergy support, smoking. So all those were good points. Then you did ask about my being well, staying at home. So that was a good point. You were concerned about this, that she's not doing job, and you asked about the BMI. So 25 is all right. So you confirmed the name and NHS number. Then you went to details of the examination to rule out some other causes of local causes of postmenopausal bleeding. And then you did the management. I would like to improve upon. I'll just tell you in a bit, okay? So the top part till 5.5, 6 minutes, the station was really 100% passing. Till 6 minutes, unless we came to the management part. So management part spoiled the station. Otherwise, till 6 minutes, it was absolutely passing station. The way you talked to the patient, the way you took the information gathering, I was very happy about that. So your communication with the patient is 2 by 2. Your information gathering is 2 by 2. However, I cannot score much in the applied clinical knowledge. If I'd be very lenient, I can give you borderline, but I would be very clear in my management plan as per the tamoxifen and postmenopausal bleeding. So patient safety was also, I was not understanding the exact intensity of the situation. I had to be very sure that yes, the only way we are going to take sample is the camera technique. And then its outpatient had to be there. So you generally, you realize, yes, you realize that I can understand, but then you couldn't like control the situation. So even if after saying to Papal, if you would have said this thing, that this is one option, however, it is not suggested in the patients who are taking tamoxifen. So, even then it would have been covered. All right.
Otherwise, we don't do endometrial PIPAL anymore. We don't do it. It's very,
In a
very
postmenopausal patient, only postmenopausal patient without high risk, the Green Top guidelines still suggest, so for examination point of view, yes, we do PAPAL, right? Hysteroscopic biopsy is only for intermenstrual, postcoital bleed, or the high risk patients, as per the Green Top guideline, endometrial hyperplasia. First step is PAPAL. We are going to follow that. However, here it's gold standard with tamoxifen direct. It is going to be the hysteroscopy.
But practically for postmenopausal bleeding, we don't do PIPAL at all.
For the HMB, as per the NICE, we would never do the blind biopsy as per the recommendation. For postmenopausal bleeding, remember, it is the first option that would be taken into consideration, okay, as the first option. Now, the information gathering was correct. You took the detail of the breast cancer as well. Now, coming to the patient safety, hysteroscopy for diagnosis is the patient safety. I was saying somewhere in between that I would like to stop this drug. So I wanted you to say there clearly that we are going to refer you to the treating doctors of the breast cancer. As to continue this medication or to stop this medication would be their decision, right? And be very open and honest. In the entire station, I could not hear that, yes, it could be some underlying cancer. Even GP gave a clue. But you did not touch this point at all. What can be the reason behind the bleeding? There can be 2-3 reasons for this. So at least enumerate the possibilities. And the team of doctors is going to take care of this decision. The breast cancer treating physicians and the ones who are going to treat your gynecologist, the consultant, all are going to be in this condition. Now, when you're taking this drug, tamoxifen, it's going to be a team of doctors who are going to take care of this condition. It's going to be a combined management plan from the breast cancer treating doctors, and along with that, my consultant gynecologist. The definitive plan in this situation is that any patient who is taking tamoxifen for the treatment of breast cancer and does have the postmenopausal bleeding, the suggested treatment is that with the help of a camera, which is passed from down below, we need to visualize the womb and take the tissue sample. Now, the lining of the womb tissue sample, if it comes out to be normal, we are going to follow you up. However, if it comes out to be thickened, there are 2 possibilities. At times, the thickening of the lining of the womb is without the abnormal cells. If at all this is the situation, the team of doctors again will decide if the hormone coil is suitable for you or the oral hormone pills can be taken in this situation, as it has got little concern regarding the breast cancer. If at all, it would be thickening of the lining of the womb with some presence of abnormal cells as well. I'm afraid that would be a situation where we would discuss with you removal of the womb with removal of the ovaries and the tubes as well. There can be an underlying cancer. The possibility is always there. However, it's way too early to comment with only the episodes of bleeding, Camila, that what the situation would be. However, as soon as we get the report, we'll be in a right position to talk to you about the diagnosis and further management. I would like you to maintain the healthy weight and general exercise, which definitely is protective for the prevention of the womb cancer. Would that be all right? So for now, if you agree, I can take a detailed consent for the camera testing. We can do that in the clinic after giving you some pain relief. and send the tissue sample for the report. Once the report would arrive, we can move forward from there. Would that be all right? Yeah. Now your applied clinical knowledge is done. Got that? So these are the things which I want her to clarify, that what does tamoxifen postmenopausal bleeding mean? These are the points which you need to cover.
Yeah.
So you have to mention that yes, underlying cancer can be there. She's high risk patient for this. So your definitive plan and your general management plan as well. So if you do this, your things are done. Now coming to the point that was it a normal thickness or not? So the cutoff as per the TOG article for tamoxifen is more than 7 mm. Till 7 mm, it's normal. So any patient who has an incidental finding for the postmenopausal bleeding is not there, only incidental finding of the thickening, it would be on more than 7 millimeter that you're going to do hysteroscopic biopsy. However, any patient who is symptomatic, then you're not worried about the thickness. Then directly, yes, we have to do the biopsy because it can be polyp, it can be many other things, right? Tamoxifen is notorious to cause the growth like polyp as well. Okay, so this is what you need to remember. The hysteroscopy here, Girija, outpatient is the preferred one. If she has some concerns or if you think that it's going to be a therapeutic, you need general anesthesia, only then we do the inpatient. It would be outpatient hysteroscopy as the preferred one. Dr. Sabia, what do you want me to repeat, please?
About the thickness.
Okay, 7 millimeter, more than 7 millimeter is the cutoff for the endometrial biopsy for tamoxifen, right? So if the patient is having no symptoms and it's more than 7 mm, you will take biopsy. However, if the patient is having bleeding, symptoms, and whatever the thickness is, you will do hysteroscopic biopsy. Okay? The TOG article, postmenopausal bleeding, my dear Dua.
Can I ask one question, Dr. Sidra?
Yeah, please. More than welcome, please. Yes, sir.
I just need to ask, do we need to mention about referring to oncologists regarding alternative tamoxifen at this stage or not?
Yes. When she will, in exam, what happened was that she immediately said that, why is this happening with me? And you said that, yes, tamoxifen is a treatment for the breast cancer. However, it has got an effect of increasing the thickening of the lining of the womb. So because of this drug, this happens with the patient. So she immediately says, okay, doctor, now it's over. My breast cancer is cured. Now I want to stop it. So your answer is that she should not stop it. What you're going to say is that we respect your concern and the stress of taking this medication. We are going to refer you back to your treating doctors of the breast cancer. They are going to decide best for you whether the treatment is over and they need to stop this medication, or they need to give some alternate or continue the same to avoid the recurrence of the breast cancer. So this would be their decision. They will see the situation and decide best for you. Would that be okay, Camellia? So this is the answer. Okay, they are going to decide whether the tamoxifen has to be continued or the treatment is over, it should be stopped, or some alternative has to be given. 3 options. Okay. Right, Sarah?
Thank you.
Thank you. Thank you very much. Okay. So any other question, please? Jyoti, are you clear now, my dear, about the applied clinical knowledge?
Yes,
I'm sorry.
clear.
I'm
The only
sorry.
station which I
I
hadn't.
know. I'm so sorry. I didn't know that this was the only one. I would have tested you in something else, but it came out.
I touched, anyways, I haven't studied much, but touched a little bit of everything except for this one. But
Oh, I understand. Only the applied. See, that's why you were very good in the upper part of the station. I mean, the top or the middle. Till 6 minutes, I was so happy the way you had been going. But when you came to the management, I could understand that, the recommendations are not revised or that thing was missing. So your tone was really good, Jyoti, today. So I appreciate that now. The tone thing, which I wanted to hear from your side long ago, that was evident today. So just keep practicing in that manner, okay? And Jyoti, I would make a suggestion, please, because you're working there. See, communication is not a problem for you. The problem is you don't have much time to read the things in detail in terms of revising the recommendations. That's your problem. Okay. So what you have to do is that please try to make your algorithms like stick-ons, like, okay, so only tamoxifen, this, 4 lines and your recommendation time. You don't have much time to read, the entire NICE guidelines or the entire GTG. Make your 5 recommendations and just put stick-ons or your templates. That would make your things very easy. because you don't have much time. Like, you know, the way I make the algorithms. Okay, this algorithm is sufficient to do your station. That is what you require in the management.
Taken some leave to sort of sit and read. So
I understand. I understand. I'm all there to help. Whenever you're stuck up, please let me know. Okay. All right. Thank you very much, Jyoti. Thank you. All right. So Girija is happy with your presentation, and Ramya as well. That's lovely. Always support each other, help each other, and this is how we go. All right. So let's go to the station number 4. And can we have Dipti here? Hello, Dipti.
Hello, Dr. Subra.
How are you doing?
Yeah, I'm fine. How are you?
I'm very well. Thank you very much. So station number 4, the 2-minute star here. And group A, where is Atya? Dr. Atya? I've written in the group as well. Sarvat? She messages me privately that not replying.
Athiya is, I think she will be doing clinic because Saturday she is busy in the clinic.
I see. Okay, no problem. Right. Okay. So maybe actually she messaged me earlier that, you know, there were a few queries in the on-code. That's okay. All right. So station number 4, let's start the 2 minutes. Dr. Sabiha, sorry, Dr. Dipti. Ready?
Yes.
Good luck.
Yeah, thank you. Next slide, please. Next slide. Can I see the previous one?
First, complete the slides, please.
Okay. Hello, I'm Dr. Deepthi. I'm one of doctor in the oncology clinic today. May I confirm your name and age, please?
It's hello, doctor. Dr. Amanda Thomas. I'm 55 years.
And how may I call you?
Amanda is all right.
Okay, Amanda. Amanda, I can see that we are here alone. And do you want someone along with you, as I have to discuss something very important with you?
Thank you very much, doctor. Nobody can come at the moment. I know the situation, doctor. I know 2 weeks back, doctors told me that, yes, it's a vulval cancer. And they wanted to discuss with MDT. And today they have to tell me about what's the plan for the management, doctor. I'm trying to be strong, doctor. Thank you for supporting.
Okay, I can understand, Amanda, your condition. Amanda, I'm sorry that you have come to discuss your condition with my consultant, but due to some reasons, my consultant is not right now, not here. So is it okay that I will carry forward this consultation with you?
That's okay.
Okay, thank you, Amanda. So Amanda, can you tell me in details about the condition? What happened to you when this
it was actually a growth. It was an ulcer. I could see for around 1 month time that was increasing in size, and then I came to the doctor and they said that it's a bigger one. We need to take its sample. That was not very healthy looking, So they took a sample and they said it's vulval cancer. They came to know. So that's it. Yeah.
Yeah, I mean, I can see, I can understand that you are going through a very tough phase. And may I ask you a few more questions to know more about you, Amanda?
Yeah.
Amanda, are you following your GP for any medical condition?
Otherwise, I'm okay.
Okay. And you have any surgery in your tummy or down low for any condition?
I had cesarean section.
Okay. Apart from that, anything else?
No.
Okay. Amanda, are you allergic to any medicine?
No.
Okay. Amanda, how's support at home?
My support is okay, doctor. Everybody's worried because of my condition.
Amanda. Okay, Amanda. So I have some notes from this your history and your I'm having findings. I have confirmed your name and NHS number on this, and as you already know that this is the cancer of your vulva, and the MDT meeting was happened. And they have discussed your case in the MDT meeting, and as it is a stage 2 of cancer of vulva, and they have decided there are two treatment options for this your condition, Amanda. Either you have the removal of your whole vulva that we called as the radical vulvectomy, and including because your cancer has spread to your bladder, so we have to do some extensive surgery, so which needs the removal of your womb, your both ovaries and your tubes. And as I will explain you. This is the diagram that this cancer has been spreaded to the bladder also. So we have to remove this whole part of your vulva. We have to remove your womb, your both ovaries and your both tubes. And also we have to make a bypass because as this for your urinary drainage that is called as the LL conduit. So it is a very expensive operation, Amanda. And another one is there's some rays, energy rays, which is used to destroy these cancer cells, sinister cells, along with or without some medicines which will also damage these sinister cells. So the success rate with these both of these options like the surgery and these rays and these medicines is the same, but however because it is the most the surgery the operation which need to be done is very extensive, so the suggested treatment is from the MDT team is the rays, the energy rays which is used to destroy your cancer cell. Am I clear, Amanda?
What would be the benefit of that? I'm just worried that won't it affect my sexual life? I'm in a same-sex relationship and my partner is too young.
Yes, Amanda. Because that operation is very extensive actually, and obviously after doing this rays which are given to destroy these cells, this cancer, there you have some problem while you had your intimacy, you have some physical contact with your partner. Uh, but after doing the surgery, the most important thing is that it is psychologically because it will remove the whole of your vulva, and so some of the patient might not feel good enough after having that operation. So
the radiations you're talking about would not be affecting my sexual life. My friend, she had it and she was saying that she had a very difficult and painful sex after that. So it narrows
Yeah,
down
after
vagina, I've heard.
Yeah, yes, Amanda, that is correct. That these radiations causes the narrowing of your vagina, and you may be given the dilators for that to for the vaginal narrowing. So it will help you in having some relationship with your partner after having those radiations.
Okay. So what do you
No.
think is the best now? What should I undergo?
uh, as the MDT team has discussed, they have suggested that the radiotherapy is the better option for you because the surgery is very much extensive for you. So I will give you some patient information leaflet. You go through this, and I will also provide you some support groups, some excellent support group. You go through them, you talk with them, and then you can have a decision if you want. I will appoint. I will also appoint another a meeting with my consultant. So you with your partner can, and we'll discuss in detail more about the treatment modality.
I understand that, doctor. All right.
Okay. Anything else you want to know? Any other?
That's okay. I mean, I understand that. Would I be able to make it till next Christmas, doctor?
Uh, well, because it is because this tumor has already spread, so it's better we'll take a decision as early as possible, Amanda.
No, I don't want to make a delay, doctor. I just want to tell you that do I have time to live till next Christmas?
Amanda, I can understand your condition, Amanda, but the prognosis in this case, in your case, is some out of 100, 50 to 60 patients do well after 5 years of the treatment. Am I clear?
Yeah, I understand that, doctor.
Okay,
Thank you
so
very much.
so I'll give you these patient information leaflets, and I will also give you these Macmillan support groups. So you go through them, and I will also appoint another appointment with my consultant. So you come with your partner, and we'll discuss it in detail.
Thank you very much, doctor. Thank you.
Thank you.
All right. A difficult station, Dipti, yeah?
Actually, I don't know what I have to do in this station. I'm so confused. Means everything is given. What I have to ask?
I
So
know
sorry.
everything was given. What do you have to ask? So many things were given, but should you stop her from alcohol or smoking or
Yes,
healthy
yes.
lifestyle?
Yeah.
So the information gathering you took, was it sufficient for the domain?
Actually, I was a bit confused because in history, actually, these positive findings were given. The whatever the positive findings, actually, we think I thought that the whatever the positive findings are there, so they are given. So whether I have to ask or not, I was confused. That's why I didn't go with the pattern, that menstrual history, obstetric history, and all that. So I am very much confused in this station. I don't know
Let's
actually.
talk with the house here. So an open house question from Sidra that this history is given. So the history with Dipti took, was it sufficient, or would you like to repeat these points in the information gathering, please? All of you, if you would have been at Dipti's place on the hot seat, what would you have done? Dr. Sabiha, Abir, Girija, Ramia, Dua, were these questions sufficient?
What I understand,
Some more history
Sidra,
needed apart from this.
Sorry, Girija, come again.
Yeah, some more history, like her medical, does she have any medical conditions, and about her cervical smears, sorry, cervical screening, and family history of cancers.
Okay.
Support at home is very important here as well.
Support
That
at
is
home.
given. No significant family history was given actually.
Yeah, that is given.
Okay.
Medical
So-
history is not given, and cervical screening
Yeah.
and
Okay, so if
I have
Girija, you
asked.
would have been there, you would have followed the template, but you would have missed these things which are given. I mean, you would have skipped
no,
these.
I would have acknowledged that I can see from your notes that this is this there,
Okay,
and I will ask the additional points.
I
What
get
are
that.
missing in this?
Dr. Sabia, you wanted to say something, please?
No, actually, girls, they already discussed it. Actually, for me, for this patient, the most important thing is the support, how she's coping and who is Yani supporting her, and she need any support or any right.
Correct.
Of course, the history is examination is important, but at this stage, the topmost is her support. How is
So
she coping?
you will do the template of information gathering, and you will skip these points, or you just acknowledge that I've come to know about that this is done, and the rest points you're going to ask. Am I right?
Yeah, that is my understanding and my question also from you. At this stage, why we will Yani go through all the too much information gathering?
Okay, we'll go through that, but not with Yani. Okay, right? Okay, all right. So any other person, please? Anybody who would have done it differently, or Dipti has done the correct way? Girija wants to skip or only acknowledge these points and then take the other one. What would you do? Okay, Ramya wants to take sexual history as well. All right. Okay. So Dua, how would you do this station? Dua?
Hello.
Yes, Dua.
Sorry, Dr. Seda, I didn't follow from the beginning. So that's why I didn't talk. I'm sorry, I didn't follow this station from the beginning.
I understand. Okay, no problem. Relax. So, whomsoever I've asked here was that Garija, Sabiha, Jyoti, Ramya, Abir, Dr. Sabiha. What did I tell you in the first station always? That first things which I was talking to Dr. Sujata as well, please see, is it an SPT or is it an ST? What is the second thing you people see? Which was my basics of the teaching to you guys for a station. Do we have any information gathering in this station as a domain to be tested, please? Anyone out of you noticed that? Is information gathering being tested in this station?
Yes, no.
Yeah.
Anyone noticed why I have given the history already, most of the things, Dipti?
Yes.
Because there's no information gathering there. So the most important things I'm providing myself. So you don't have to worry about this thing. Just ask important questions which are important for the management. You don't have to follow the template and come to the management because discussion is way too longer. You have to discuss the communication with the colleagues. You did not touch at all. Who is going to take care of her in the if radiotherapy is going to be done? The radiation specialist, the radiation registrar, the radiation nurse specialist. You have communication with the colleagues as a domain. And why did I not tell here so that Dipti doesn't feel that she's the only one? Dipti, everybody was like you. Nobody noticed that information gathering is not there. Neither Girija, nor Ramya, nor Jyoti, nor Dr. Sujata, neither Dr. Sabia, and nor Abir. None of them.
I did not give importance to read this one.
And that
But
is
from
very
the station only, my understanding was that we have to talk about her current situation, her support, and how she will be doing the radiotherapy, and who is going to take care for her during that period. Just I'm understanding that we should talk about that issue only with that.
correct. But see, you don't have a scorecard for information gathering, please. So why are you people worried about the template? Go forward. And that's the reason none out of you is thinking that what would we talk about in the communication with the colleague. Am I right? None of you
Dr.
thought that
Sidra,
what
what
we
is
are
the
going to name
reason?
for this domain.
What is the reason? I will tell you. What is the reason we did not see this scorecard? You know what is the reason?
Yeah.
Multiple tasking.
Oh, please, Dr. Safia. So that means that when I change the station,
I don't take a break for a second, but you guys start like, okay, no problem. 2 minutes are done. So let's do the other tasks and then go back. Huh? All right. So yeah, you must have missed that because of lack of attention. All right. Please don't do that to me. I'm giving my 100% even till the last time that yes, you people have to do these things. This is important. Please always see an exam because that's what the scorecard is. So that's the reason that the history was given here. There were many good points, Dipti, in the station. Your introduction was good. You're asking the name and talking to Amanda, being in a very empathetic manner from the start and asking about the support, empathetic sound. That was all very good. You did ask about the medical, the surgical history, and the allergy. I like that because that's not your information gathering. That's also your applied clinical knowledge and patient safety because she has to undergo some aggressive management now. So you did mention MDT. That was very good. You did tell me about the radiotherapy as defined suggestion from the MDT. And you gathered up that she's in same-sex relationship. She's worried about this. You offered her support. You could not handle her last question. Would I be able to survive till Christmas? So that was a difficult question. You were shaky about that. I'll tell you lines for this, okay? No worries. And then extra questions and information gathering was not required in points to improve. And if it is given that she's smoking or alcohol, you can give a general lifestyle advice to her because this is affecting her life. And of course, with an aggressive management like radiotherapy or surgery, it's going to worsen her healing and worsen her recovery. So you can say that I can connect you to the smoking cessation program because stopping smoking at this point in time is going to aid and help us in your recovery. So for this, if you could give it a thought, okay? So
Actually,
that would
I
help.
was so confused in all this. I forgot.
I know. Relax, no problem. This is how we learn. Dr. Bindu, when you're listening to the recording, we are missing you. Please accept our deepest heartfelt condolence on the loss of some family member. So we are missing you today. I hope when you go to the recording, you're going to see what Dipti did, and I'm sure you're going to enjoy Dr. Dipti's presentation. So we miss you all. Okay. So coming to the key, please. The important thing is communication with the patients and the relatives. You can use a visual aid to make her understand the surgery, as it was a detailed surgery which was given here. That radical vulvectomy, THBSO, anterior exenteration, ileal condu, and then it can be radiotherapy as a second option. Suggestion is radiotherapy. So your communication with the patient was fine. You were in a logical sequence, and I will tell you that how you're going to use a visual aid for this. All right. So communication with the colleague was absolutely missing because you people did not see that this is a domain. So it's a team of doctors, oncologists, the oncology doctor, the cancer radiation doctor, the radiation therapist, the surgeon, the cancer surgeon specialist, and a general surgeon as well, the specialized nurse for the cancer field, a counselor to cope with the situation, and cancer support groups. So the only thing mentioned was the Macmillan support group that comes in the colleague. Well done. So please keep a note that you've got radiation oncologist, the radiation oncology registrar, the radiation therapist, and the oncologist nurse as well. You were very sensitive, talking in a sensitive manner, and empathy was there as well. The MDT thing was fine, and open and honest about the complications you were, but I wanted to know a little more about the radiotherapy complications, but we didn't come to that point. Reason was that we didn't reach that point, actually. Oh, lovely laughter from a baby. Okay, thank you very much. All right. So coming to the point, I would be saying that, see, in this situation, that what was her name? Amanda. Okay. Amanda, cancer unfortunately has involved the other structures. And if you see here, this is the opening of the vagina and the surrounding area, we call it as vulva. And in early cancer, it is generally suggested to remove the local affected area. But it is the condition we are facing now. We are going to remove the cancer area, the womb, ovaries, the bladder, and the tubes which connect the kidneys to the bladder. Now, bladder will be directed outside. So it is expected to increase the discomfort, and the complications and the risks are anticipated to be higher in this condition with the current stage of the cancer. On the other hand, the team of doctors, they suggest the strong x-rays which are given in a controlled manner. Now, the options which are available is surgery, which would increase the morbidity, anesthesia risk, and complication and damage to the surrounding structures. Risk is there. The suggestion of the team of doctors is to have the strong x-rays which are given in a controlled manner. However, it has its short-term or the long-term complications in terms of
a sore bladder, upset tummy. Vagina tends to shrink and loses its stretch, and vaginal dryness also occurs, for which we are going to give you certain creams, lubricants, and the dilators would be given for you, your sexual comfort as well. Moreover, I would like to tell you that everyone is different and the side effects, they vary from person to person. So these side effects, they tend to start in few days and gradually they worsen during the treatment, and they do improve after around 2 weeks of ending up of the treatment. I know it's very difficult, but out of the available options, the team of doctors consider it to be the best option. Again, it would be your decision in the end, and we are here to support you in your decision. The last option we can have is the drugs, the medications which kill the cancer cell. But again, they can decrease the blood counts in terms of your white cells and the blood making up and carrying the oxygen. We call it as hemoglobin. And also it can have some sort of a bruising, bleeding, sickness, mouth sores, hair loss, skin changes, the appetite is decreased, and the bowel habits are altered as well. How do you feel about the options available to you? Would you like to think about the options suggested by the team of doctors? Do you have any concerns regarding choosing that option, please? I'm here to answer all your concerns. So now your job is done. Why did the information gathering was not there? Reason was, why did we take it out as a domain? The reason was that we've got so much to discuss in this case. The pros and cons of each. Your task is to do the MDT discussion and make her realize that this is better for her. So a lot to be discussed about surgery, a lot to be discussed about radiotherapy, a lot to be discussed about chemotherapy as well. So if I make the outline, it would be introduction agenda, no information gathering, only 3 important points which are for the safety: her morbidity, medical, surgical, allergy, that's it. Right? Explain the result of the MDT meeting, management plan, address her concerns, and it should be a mutually agreed plan, and tell her about the follow-up. That's it. Your job is done. All right. Now, there's certain things like she says that would I be better, or she's concerned because she already knows that it's an advanced cancer. So your emotional well-being, Amanda, is as important to us as your physical health. And everyone needs support of some kind during difficult periods, and facing up cancers can be one of the most stressful situations. So we can refer you to a specially trained member of the team to make you feel better and for the counseling. Would that be all right? Okay. Now, I would like to ask an open question, please, that anybody can answer. Doctor, would I be able to make it till the next Christmas? Anybody would like to answer?
Yes, me.
Sure, go ahead.
So I would tell her that that's a very difficult question to answer. Though because those studies show us that there is this much, I don't know the percentage exactly, this much is the percentage of people who survive for 5 years and do well for 5 years, but it varies from person to person, depends on what treatment we give you and how much of complications how much of complications you have and how extensive the treatment and the disease is. But it'll be very, very difficult to answer that question.
All right. So I'll put it in the other way, that what can we do in this situation, right? So she was Amanda. Amanda, I'm sorry. The trouble is that none of us knows actually. It depends upon how the patients, they respond to the treatment and many other underlying issues in terms of their background health. I realize that this uncertainty must be very terrible for you, Amanda, and I'm sorry, but there's no way to predict future. However, what I can do at my places, that put forward the symptoms and the signs that you could look for to see if the situation is deteriorating, would that help you? So that's it. That's what you can say. It's this uncertainty is terrible. So there's no way that we can predict future. However, this percentage which Jyoti or Dr. Dipti is referring to, that varies from patient to patient as well. I mean, according to the background health status, how do they respond? It's not something which is essentially true for this patient. So the only thing you can do is that you can tell her the symptoms and signs that she can look for to see if she's deteriorating. That's what you can do. We cannot predict the time. So unfortunately, we are helpless in that condition.
Okay, so just make those lines, what I've said so, and keep your answer ready, because under the stress of exam, it becomes very, very difficult to answer this. As like Dipti was just blank when I asked her that would I be able to make till next Christmas. She was like, oh, how to answer this question? That's very difficult. Okay, so you say that, yes, the trouble is that none of us knows, because it varies from patients to patients that how do they respond to the treatment. And the uncertainty is very terrible. However, we can't predict the future. None of us can predict the future. So we are here to help you in terms of giving you those signs and symptoms, putting forward so that you know that if you're deteriorating, so that we can take the things accordingly. Okay, so this is how you're going to make it in a diplomatic manner. Thank you very much, Dr. Dipti. I hope you all learned from this station well.
Yes,
And thank you very
I'm
much
so
for
sorry, actually.
no problem, Dipti. This is how we learn. And again, I would say you were on the hot seat. So it is acceptable that you missed out. Those who were listening, they missed out it as well. So please don't feel bad about it. Everybody is like you and everybody is same as they did not pick it either. Okay. Thank you very much, my dear. Good luck for future. Thank you. All right. So let's go to the station number 5. And we've got Girija here. So this is last station of the day. I'm going to provide the 3 stations, VIN, risk reducing self-injure oophorectomy, MDT letter as a recording from the other ones, because we don't have any participant. However, I will do that privately with Fauzia whenever she would like to do, as soon as her internet would be better. So can we have Girija here?
Dr. Sidra, I'm here.
Okay, that's great to know. Let's do the station, Girija. 2 minutes, starting, and good luck.
Thank you.
Girija is looking at the domains.
Yes, yes.
Go ahead.
Okay. Can you go to the previous slide, please?
Sure, please.
Okay, there's one more. Okay. The first slide.
Yeah.
Okay. Hello, I'm Dr. Girija, one of the doctors here in the gynae clinic today. May I confirm that you're the daughter of Mrs. Clara John?
Yes, I'm Sarah. I'm Mrs. Clara's daughter. Yeah.
Okay, nice to meet you, Sarah. Is it okay if I call you Sarah?
Yeah, that's okay.
Okay. So I believe you're here to discuss about your mother who had some bleeding recently.
Yeah.
Yeah. So can you tell me more about it?
My mother is otherwise fine, but the only thing is that it's been around 3 years that she has having condition. She's having Alzheimer's disease. So she is having forgetfulness to a level that she doesn't recognize me or my brother or my elder sister. So we can't leave her unattended, doctor, to the level that she doesn't understand. I mean, this is something to eat or this is something not to eat. For example, 2 days back, she was just eating a soap from the soap dish. She just took over. So we can't leave on her own. Like she requires an attendant to be with her. We were comfortable otherwise. I mean, in terms of her appetite and in terms of her daily routine, despite that we keep her attended with a nurse is also there who comes to look after. But 2 days back, she had one episode, and there was another one with the reporting of the bleeding. So I was a little concerned. I came to the GP as well for this. He said that now we need to, with this age group, the bleeding should not be there. So I just wanted to know what would be the plan and how we have to look after her.
Okay, I'm really sorry to hear about the condition of your mother, Sarah. I know it must be so difficult for you to be in this situation, and I can understand also how difficult it must be for her to be in this situation. So is there enough support for you? How is she coping now otherwise?
Yeah, thrice of us, we are three siblings, and we just take care of her. We divide timings. Moreover, in the morning, I told you that we have got help for in terms of attending to there.
That's good to know. I really appreciate that you're taking such good care of your mother, Sarah. That's really nice to know. Okay. So you said she had 2 episodes of bleeding, right?
Yeah.
Okay. So we would discuss about what we do next for her, and as well as I will provide you with a management plan for her, and together we can decide the best treatment for her. But before that, is it okay if I ask you a few more questions to know about her general health overall?
Please, yeah.
Okay. So does she have any medical conditions apart from Alzheimer's disease?
No.
Okay. And is she on any regular medications for this?
Some tonics, because she turns out to be weak. So it's just some tonics, multivitamins. That's it.
Okay. And has she undergone any operations in her tummy or down below in the past?
One of us was a cesarean section. Rest, they were rest no operation. Yeah.
Okay. And is she up to date with her cervical screening?
Yeah, that was over, I think, 2 years back, if I'm not wrong. Yeah.
And all have been normal so far, right?
Yeah.
Okay. And otherwise, how is she overall? How is her health overall? Does she have any particular conditions like diabetes or high BP?
No, nothing like that. No.
Okay. And is she mobile otherwise? Is she able to walk around?
She is, and that's a problem. I mean, we have to keep her, under supervision for that matter, that she doesn't harm herself. Yeah.
Okay. And are you aware of her weight to height ratio, Sarah?
Yeah, that's pretty normal, somewhere around 22 to 25. I mean, she's otherwise normal weight.
Okay. And is there any history of blood clots in the legs or lungs in anyone in your family or her?
Nothing like that, no.
Okay. And may I know, is there any history of any cancers in the family? Cancer of the womb or neck of the womb or ovaries or breast? Okay. And since the last 3 years, she's been having Alzheimer's, right?
Yeah.
Okay. And is there anything else you want to add to this information that you have given us?
That's it. I'm just worried. I just wanted to take a decision earlier because I don't want to compromise, her health.
Okay. And can you tell me, was she examined for her condition in the GP surgery or anywhere before?
Examine exactly?
Was she examined for her tummy and from down below?
No. Actually, they just asked for the internal scan.
Okay. Okay, Sarah. So I have her ultrasound scan report here, and I have confirmed her name and NHS number on it. So the scan, as such, there is no growth or any abnormality seen. Only thing is the lining of the womb at her age. Usually, we would say that up to 4.9 millimeters is okay. So 5 is a little on the borderline, kind of, since she has stopped having her periods a long back. And as you already know, in her age, to have a bleeding, it is not normal once you stop getting the periods. So we would definitely need to evaluate this further, why she had the bleeding. Okay. And there could be many causes for this. Usually at this age, the most common cause for the bleeding would be, which we call as atrophy, where the lining of the womb becomes thin, and because the periods have stopped, so the hormones are not there, so there tends to be some bleeding. But sometimes there could also be some growth coming from the lining of the womb, which are like skin tag like growths, which we call as polyps. Or there could be a thickening of the lining of the womb, or very rarely there could also be a cancer of the womb as well. So to know exactly what is the condition in your mother, we would need to evaluate her further by doing a camera test to have a look at the inside of the womb.
I understand. Yes, I'm ready for that, doctor. Go ahead.
And also, Sarah, I would like to tell you that because it would be difficult, this procedure usually we could either do it in the awake state or by putting the patient to sleep. But in your mother's condition, it would be more appropriate for us to put her to sleep and do the procedure, because she may not be able to cooperate for the awake procedure. Am I clear so far, Sarah?
Yeah, okay.
So before we move on to deciding about the procedure, Sarah, I would like to know, is there any advance directive that your mom has given about any sort when she had the mental capacity to make decisions?
Advanced directive as in? Sorry, doctor.
Advanced directive, something like advanced decisions which we make, saying that if in future we have some problems, what sort of treatment we can undergo, or we deny to undergo any sort of treatment. Is there
I don't
anything?
think so, doctor. Not in my knowledge. I mean, she would never be thinking when she was well that she would have this condition actually. So I don't think so. Yeah.
Okay, so what do you think she would have done at this point in time had she had the mental capacity
Definitely,
to
whatever is
decide
best for her condition, she would have agreed
she
to
would have
that.
definitely gone ahead with the procedure,
Yeah.
I think.
So no problem, doctor. Don't worry, please. I'm here to sign and take responsibility. So don't you worry about that.
And also, Sarah, I would like to know from you, is there any legal procedures you have done to have a power of attorney for making decisions for her health and welfare?
What is that legal procedure, doctor?
There is a form which we fill, and that would the power of attorney basically has making decisions for someone who cannot make a
No
decision
problem.
on their
I
own.
can fill the form. I can take all responsibility. I'm her daughter, so don't worry about that. Yeah.
Okay. So there is no legal procedures done so far, right? As much as I understand from what you're telling me.
Legal procedure, I don't understand. I mean, I'm her daughter. What I understand is that I can take decision for her betterment, right?
Yes, I completely agree with you, Sarah. And usually when there is a condition that comes to us, if the person has the mental capacity to make a decision for themselves, if they can understand and retain the information and make a decision by weighing the pros and cons, then the person decides. But in case they can't, then there is something called as a power of attorney, which we give to somebody else to make a decision for them. So that is a legal procedure which we do prior to the person losing the mental capacity, basically.
Nothing like that is available. However,
Okay.
I'm ready to take the responsibility and sign the consent, doctor.
Sure, Sarah. Okay, actually, we would have a best interest meeting, and definitely we would make a decision in the best interest of your mother. And we had a meeting of the team of experts, which we call the multidisciplinary team. And the best option available for your mother was the camera test that I mentioned, and taking a sample and sending it to the laboratory. And we would also include a mental capacity advocate in our meeting, and then we would go ahead with the procedure, Sarah. But this would be in the best interest of your mom.
Would that be a delay in that?
Yeah, I would just involve my consultant here, and the team of experts would sit and decide. And as soon as possible, we would do the procedure, Sarah, because we need to find out if there is something wrong. But we need to do this, and we need to take a decision.
It's okay. All right, doctor. Thank you very much.
Okay. Is there anything else you would like to know from me, Sarah?
No, that's okay. That's okay.
Okay.
I'm ready for that, doctor. As soon as possible, if you're just going to take a decision, we're ready for to proceed with that.
Yeah, sure, Sarah. I will also provide you some written information about this, and I will also write back to your mom's GP about our agreed plan.
Thank you very much. Thank you.
Thank you, Sarah.
Right. How did the station go? Alzheimer's. Yeah?
I couldn't explain the power of attorney part of it. I didn't know how to put it in words.
But that was a good one. At least you were not trapped that I'm ready to sign the consent. You were
No,
not.
Dr. Sidra, I took sign of the patient in my exam. I had the same station.
Oh, I see. So that's the reason you're not taking sign.
And the daughter came and I literally, she said, okay, I'll sign it. I said, yeah, sure. I'll take your sign now and I'll do
Oh
the
my
printing.
That's why when I was, insisting again and again, you were like, no, today, no sign.
Yeah, I was like, no way, I'm not taking your sign.
That's wonderful. So this is how we learn. Very well done. So you're talking to Sarah. Nice to meet you. A good rapport building in the beginning. Your information gathering with an open question. To feel sorry for the way the daughter is going through because of mom's health. Offering support, asking about that, how the things are going. Medical history, her cesarean section, her surgical history, cervical screening, her BMI, the VT history, the family history of cancers were all perfect. Telling about that, confirming name and NHS number of Mrs. Clara John, that was perfect. And telling about that the MDT has decided for the camera testing, that was perfect. Now the advanced directive you did ask about, I'm going to tell you that how you have to phrase that, but that was correct. The lasting power of attorney, you did mention. So again, that was the second step, and the third step is the best interest meeting. So the legal advisor came to that. So that was all a very, very good choice of sequence. However, in the entire station, I could not see any possibility of being open and honest. So what can be the reason? You were right that mostly it can be thinning out of the vagina, and that can cause the bleeding. However, this can be some complication, like in terms of having the thickness with abnormal cells or without abnormal cells as well. Am I right? The same thing which I told Jyoti.
So when I told all the 4 causes there, but not before that.
Yeah, not before that. So one more thing, please. Why are you people having trouble in the cutoffs, please?
Isn't it 4.9 for postmenopausal?
What is the cutoff for the endometrial biopsy as per the TOG article? Postmenopausal bleeding.
4 mm.
4 mm.
4 millimeter till 4 millimeter, it's normal.
Okay.
The cutoff is more than 4. So even if it would have been Girija 4.1, you would have taken a biopsy.
Okay.
You get my point? So you said that till 4.9 mm is okay. So I was like, no, it's not okay. 4.1 mm is a biopsy indication. Till 4, thank you, Sarvat. Absolutely right. Till 4, you say that it's all right. You reassure. Okay? So more than 4, that is from 4.1 onwards, you have to take a biopsy. This applied clinical knowledge you all have to correct. Please remind me. In my part 2, I've got a table of all the cutoffs of the entire curriculum, all the cutoffs of the endometrial thickness.
Yes,
I'll
please, Dr. Sidra, please. Okay? Yeah, thank you.
So that cutoff is like PCOS cutoff, postmenopausal bleed, tamoxifen, sequential HRT, combined HRT. All types of HRT have different sequence and cutoffs as well for endometrial biopsy. You should be knowing about that, okay? So I'm feeling that you people are not aware of all the cutoffs, or you people are not revising it for that reason that you people are forgetting. So that point was a little, I felt a little scanty applied clinical knowledge. Dr. Sabia, just remind me, huh? I'll do that. I'll post that from my part 2 thing. I'll post all the cutoffs together on one slide.
That would be very helpful.
Yeah, thank you very much. So possibility of a cancer you have to be clear on. Otherwise, Girija, I'm happy that this was a passing station. A little up and down in the terminologies was there, where you took a little more time, but you were empathetic, your explanation was correct, you were talking to the daughter in a very comfortable manner. You did take a history of the postmenopausal bleeding, about her Alzheimer's condition. One thing which I would like to add is she taking any sort of hormones for the menopause? HRT history is very important in postmenopausal bleeding, remember.
Oh, yes, I forgot that.
Yeah, that's important. Why? Because see, that's going to tell you that some sort of an exogenous estrogen is going on. That's something important. So always take a history of HRT if it's a postmenopausal bleed. So hysteroscopic diagnosis, check the power of attorney, open and honest about the risk of the endometrial cancer. Never forget this part. This is your honesty to the patient. And telling about the legal advice if no power of attorney is there. How are we going to take this step? Now, the first thing I would ensure in the case is that, is she having a mental capacity? intact or no? Is she truly having a condition of lack of mental capacity? So I'll just ask 3 questions. So I've gathered, Sarah, from your talk that yes, your mother has forgetfulness. To be very precise, does she remember whenever you talk to you about the events? Can she recall the events? Is she able to make tiny decisions in her daily routine? So the answer would be no. But your 3 statements are according to the valid consent paper. This is the lack of mental capacity. The patient who can understand the things, number 1, who can reproduce the talk, the things, the options, who can reproduce that. Number 3, who can take a decision. These 3 are the mental capacity prerequisites. So I'll just speak it up for the examiner that yes, I'm ensuring that yes, she's a lack of mental capacity patient. Does she have inability to understand? Can she retain her information? Can she make her decision? The team of doctors have decided for her, and the decision I'm going to tell you in a bit. However, I would like to ask from you that when she was in her well-being state, did she sign for her the treatment plan, if at all she would be suffering from this condition? I'm talking about Sarah when she was in her capacity of decision making, before this forgetfulness, before this Alzheimer's. Okay, so in her well-being time, when she was in the capacity, did she allow someone out of kids or any other blood or non-blood relationship to take decision for herself in any illness or medical problem? And is it in a written form? We call it as lasting power of attorney. So what did I say? I did not say it's a legal procedure. I said that did she allow, and is it in a written form? The job is done. Okay, so it's not like it's a legal procedure and something. It's like when she was fine before this Alzheimer's disease, did she allow anyone, may that be a blood relation, may that not be any blood relative? So anyone can take a decision on her behalf for her treatment plan if she has any medical disease. And is it in a written form, signed and written form? If no, that then the doctors will act in the best interest of the patient and they would seek legal advice and the court will protect this decision for the patient. Would that be all right? Please don't worry. We are here to take care of your mom and we are going to take this decision after the legal advice in the best interest of Mrs. Clara. Would that be all right? So your applied clinical knowledge is done. This is one element of the applied clinical knowledge. The second element of applied clinical knowledge is the same as I told for Jyoti earlier. That is, the definitive plan would be hysteroscopy, and after the tissue biopsy is done, if it's normal, we will follow up Mrs. Clara. And if it's going to be thickened, if it doesn't contain abnormal cells, it would be a hormone coil or the hormone pills given to your mom. However, if it contains the abnormal cells, then we'll discuss with you the possibility of having removal of the womb with ovaries and tubes as well. That all depends upon the report, Sarah. All right. So meanwhile, I would suggest to you that she has a good control over the BMI and does healthy exercises to maintain the healthy lifestyle. Would that be all right? So this part has to be there, like that of tamoxifen, because that's something important. Okay, so that's side-wise, which is important for her to understand. Okay, so initial part was correct, but this part has to be there. So the outline would be, forget this one. Okay, the outline would be introduction, agenda, information gathering, explaining the diagnosis, ensure that she has lasting power of attorney. If not, please make her understand that she cannot sign the consent. Simply say, the idea is that we will not delay the management plan. It would be the same as the MDT has decided, but it would be after the legal advice and the court protection. That's it. We do not want her signed. It's not because we are making a delay. We're not making a delay. The care of Mrs. Clara would not be compromised. The only thing is that we require a court protection for this. So address her daughter's concern, follow up, give her some reading material, Girija, so that she understands well. And you can connect the mother to the support group as well. That's it. The job is done. So it was pretty similar in terms of applied clinical knowledge. The station which we did for the tamoxifen, the only difference was that the daughter was here and the Mental Capacity Act sequence of advance directive, if not lasting power of attorney, if not the legal advice, the court protection would be done. That's it. Thank you very much. It was a wonderful station, and it was a pass station. Only the applied clinical knowledge of 4.9 mm I was not very happy with. Otherwise, it was a very good station because you did not let me sign. Students, they take the signature and they go ahead. When I do that with other groups. So today I was really
bitten,
happy.
twice shy, Dr.
Yeah.
Sidra.
Thank you very much. Thank you.
Thank you.
Thank you, my dear. All right. So, so now we don't have Fawzia here. So I think, let me see.
Dr. Sabia, please, can you answer again the question when she asked this will delay my mother treatment? How would be his answer?
It will not delay the treatment. The only difference is that whatever the MDT, the team of doctors have decided for your mother, we are going to do that under the court protection and the legal advice. And we are going to inform you accordingly. That's it. So it's not that she signs today, we are going to do that tomorrow. It's just like we are going to take a legal advice and just we'll go ahead with that. The court protection would be there. That's it. Okay?
Okay,
Thank you very much.
So Dr. Sidra,
yes,
one question. So we don't need to tell the daughter that you cannot sign consent.
See, you say that our requirement is that who has that written permission from Mrs. Chiara's side, that who can take a decision on her behalf. So this requirement is not fulfilled, right, Dr. Sabia? So that's why we are going to say that this is basically, we are going to take a legal advice. As a daughter, her concern is not that, she signs and it goes ahead. What is her concern? That please take care of my mom and do it as early as possible, whatsoever is the requirement. So you say that what we require is the treatment would be the same. What we require is the legal advice. So if she insists, no, doctor, I'm ready to sign it. You said that we are bound by law and we have to abide by the law and we are going to take a legal advice. The treatment plan would be the same. However, we'll take a court protection and the legal advice in the patient's best interest that the treatment plan would be made. That's it. Your job is done. Okay?
Okay.
All right. Thank you very much. Thank you. All right. Any questions, friends? Anything which is not clear? So tell me that how much gap do you people require before you people start the book, and what is the first book you people want to start?
Dr. Sidra, can I have a request?
I will do that, Nadra. Yes, please, Jyoti.
We are left with 3 stations, isn't it?
Yes, actually, Fawzia, she messaged me that I wanted to do my station with you. So what I'm going to do is that I'll put these stations in your recordings, right? I'll put these stations in your recordings in the drive, same as like just crop and attach it here.
Yeah, but then the request was like, is it possible to have another class? I know that's asking for too much, but still, I mean, if at all it is possible.
So what you people want is that it actually depends upon Fawzia. So she was like having the problem with internet. Moreover, one of the students, she shifted to listener. So actually she's not doing her station.
So there's only one station which we are doing.
Yeah, one station only, Fawzia station is left.
Okay, and is there any like important stations or a station with a lot of difficulty where most of the people find it difficult? So 1 or 2 of those stations and Fawzia station, can it be done in one class, a separate
I'll
class?
talk to Fawzia. Whenever Fawzia would be available, we can manage, right? Okay.
So Dr. Sidra, today is the farewell with you.
Don't worry.
Please don't say like this.
Yes, Sidra, we don't want to leave you.
Dr. Sidra, I have one request also.
Yeah.
Whenever there is exam and we book the exam, we want to listen to you, like at least some, not too much, at least 1 session or 2.
Okay, no problem. What I'll do is that whichever current batch would be there, I'll keep you along. Don't worry. Okay. I'll keep you guys.
Thank you very much.
Thank you. No problem, Dr. Sabia. All right. So thank you very much, friends. So please tell me whenever you people want to start the book. I'm going to put the schedule for you guys in the main group so that you people start the first group. One of the batches doing Sir Kunja's book. One of the batches is completing Tony. And the other one has already done the get through. So if you people want to start with Get Through, you people can start with Get Through. If you want to start with Sir Kunja's book, you can start. And whenever they're stuck up doing some station, they send a message and I answer on the voice note. What I want is that now you should start books, and doing books, please start revising from the back. So one module from the exam stations, and then starting books as well. So please write in the main group. If you people want 1 week break, after 1 week you can start. If you want 3 days break, you can start after 3 days, but at least take a start and start doing the book. Okay, tell me whenever you people want. I'm going to post the schedule, and according to that, you start the book. Everybody would be doing that. And I've got many sort templates out of this as well. I'm going to help you guys with this, okay? So don't worry. All right. So which book do people want to start first?
What is your Yani advice? Which book we should start?
You can start with Get Through, I think. Yes, Harshiba, start with Get Through. Because Oxford, more or less, you people have scanned, you know. So keep Oxford in the end. Start with Get Through, and I'll put the Get Through schedule in your group.
Okay.
All right. What would be the starting date? Is it okay that I keep the starting date from, tell me the starting date, please. So from that, I'm going to make it 1 week?
1 week after 1 week, yes.
Okay.
Or mid of March, it's okay. Whatever the group decide.
Girija, after 2 weeks?
Dr. Sidra will listen to your recordings, whatever we missed.
Okay,
So
that's
I didn't finish that either.
But that means that you won't be practicing in the mini group. Am I understanding it correct? Or you people would listen to it and then you will practice as well?
Yes, we will listen, we'll practice, and then
Okay.
we'll start books in 2 weeks.
So Girija, do me a favor then. 2 weeks schedule of revision, please put in the main group. Get it checked by me so that all mini groups they follow. I want a very organized preparation. I don't want that one day you people are doing something and the other day you're not.
Okay.
I need to keep a check on you guys. Okay.
Yes, yes.
So
You need to
whatever
be
is the plan,
behind us.
Girija,
Then only we will continue. Otherwise, we'll leave.
Girija, whatever is the plan for 2 weeks, write it on a paper, get it checked by me, and then post it in the main group once I approve that, so that everybody for 2 weeks, they make a schedule. We have to be organized. Even my April batch, they are following a schedule up till now. They're practicing in their mini groups, whatever. Now they know, I know that their complete curriculum is done. Now they've come to the revision. All the books are done. All the exam stations are done. Now they've come to the revision. So now you people have to start in that manner as well. So I need to keep a check on you guys. Okay. So that you people keep on going and keep on revising the things. Whatever we have done, if you can't speak it, it's a failure for me. So whatever we have done, that should be on your tips. That's my requirement. All the January stations were repeat stations. 14 stations of day 1, 14 stations of day 2. 28 stations were all repeat stations. So
and what are the stations, Dr. Sidra? Did you get to know?
Yeah, I've got all the stations. I'll just post it in the main group, okay? I've got all the stations of day 1 as well, day 2, and 6th and 7th both. My students are appearing, so I'll get March stations as well. So nothing to worry, okay? All of them were repeat stations.
But the thing is, Dr. Sidra, it's not going to be so easy for us. This was for ST6 people who were actually promoted.
I'll tell you that the March people are not the ST6 ones, right? They're all my ST5s.
Yeah. But this was a special event for the
that's
ST6.
why I know the passing would be higher, though the result is not still declared.
Maybe 100%.
The passing would be higher. Hoping my students they pass. For the March one, I'm still waiting. So once that exam would be just like 4 days, students, they have mock on 1st and 2nd of March. So 6th of March, 2 of my students are appearing. So we'll come to know about if there are new stations. Definitely yes, okay? So because now these are not there's no compulsion to pass them. So they're not ST6.
Yeah,
so,
there's no compulsion, but still it will be higher than
I know, definitely yes. I hope this is higher in May as well, and you all get the seats. That's important.
In the mixed exam, the trainees never fail. I've never seen a trainee failing.
So take care of yourself, friends, and please stay in touch. I don't want any of the student to hibernate, to be away. The more you're going to miss is the more you're going to get back from me. And just stay in touch, please, and keep me updated with your progress. That's why the 2-week schedule, now Girija is going to get it checked from my side, and then she'll post what you have to do, all those modules, and you're all going to follow that. After 2 weeks, you all are starting Get Through, and then that schedule I'm going to post for you guys.
Right? There are 4 books or more than that.
We have to do the Oxford, we have to do Get Through, Lisa Joel, Tony, and the new Sir Kunja's book. So there are 5 books.
So where's can we get the Sarpuja's book or whatever like
I
it's
have
called?
posted in your main group. All the books are in your main groups. All 5 books.
Okay.
Okay, all the 5 books are in your main group, main
Okay.
1-to-1 July group.
Fifth book
Okay.
called is what is the fifth book called?
Which book?
The fifth one, apart from the 4 usual ones. I mean, I know the Get, I know Lisa Joel, I know Oxford, and I know
What I know
Tony.
is part 3 preparation, Dr. Kunje. Okay, I'll see the it's page, the first page, and I think it's Kunje. Yeah, Harshipa is right. It's Kunje.
Oh, Kunje. Okay.
Okay.
Justin Kunje.
Yeah,
right?
yeah, Justin Kunje. Yeah. So I have posted that book in the main group
Okay.
already when it was published. At that time, I posted for you guys. All right. So these are 5 books you people have to do, and yes, it's there. So you all can take printouts and you start from cover to cover. One book, when it's done, you'll move to the next. So all the stations of those, you'll have repetition as well, like endometrial hyperplasia. You'll have much repetition in those books, but at least you should be scanning those books and you're not blank. That's it. Okay. All right. Thank you very much, friends. It was lovely being with you guys. It's not the end of the journey. In fact, it's starting of the journey now. Now you are in a capability of doing the station. So please go through the first session, start the revision now. And I want whatever we have done, you should speak it as clearly, as smoothly as possible. So don't think that I'm going to leave you guys. It's actually you guys who is going to stay in touch with me, and I'm going to give everything in return. All right. So Girija, please let me know whenever the schedule is done so that I can post in the main group after checking that it's an appropriate one. And take very good care of yourself, all of you, please. I love you all. Stay in touch and stay in touch with each other in the mini group as well. Keep practicing. It's going to help you all a lot. I love you all. Take care. Bye-bye from my side. Stay in touch. Bye-bye. Thank you.
Bye and thanks.
Thank you.